Hello, I'm Manoj Karmakar, your host and the convener of the ISSPS. I'd like to welcome you to the ISSPS 2021 webinar series. Today is the second of 10 webinars. If you're returning, welcome back. If it's your first time, then a warm welcome to you. I bring you greetings from this beautiful city of Hong Kong. Hopefully one day, not in the near future, you'll be able to visit us and our beautiful city. We are coming to you live from our studios at the Prince of Wales Hospital. We are part of the Chinese University, which is not far from the facility that we work at. This event is being organized by the Department of Anesthesia and Intensive Care, the Faculty of Medicine of the Chinese University, and is being organized as part of the 40th celebration of our university. This event is being supported by Sonic, a new and vibrant company that's developing some wonderful ultrasound machines not far from Hong Kong in the city of Shenzhen. If you are interested in previewing some of these equipment that they are producing, then do feel free to contact your nearest representative in your city or nearby, and I'm sure they'll be more than happy to loan you a system that you can use. And today we'll be using their system in the live demonstration. I'm proud to announce that we have a total of about 2,800 participants who are registered for this event to date, and this is the layout of the number of participants from different continents. We have participants from Australia, New Zealand, all the way to South America, from Peru, Bolivia, and Chile, etc. So a warm welcome to you all. This is a layout of number of participants from different continents and countries. The largest number of contingents are from India. Second is China, and we have many participants from Indonesia and Thailand. Anyway, so today I'm being joined by two good friends, two great teachers, to share with you our passion and knowledge about paravertebral and epidurals in the thoracic region. This will be initially started with some didactic lectures, and then later on we will have a live demonstration followed by a Q&A. The first, a good friend, Professor Bernhard Moriggl. He comes all the way from Innsbruck in Austria. He needs no introduction to those that have already attended his lectures in the past. He's a doyen in anatomy. He's as big can get. He's also been using ultrasound for anatomy since the early 1980s. So many of us, including myself and many of our peers in the field of regional anesthesia and pain medicine, have actually been his mentees, and he has mentored many of us to learn the art of anatomy and ultrasound imaging to view many of the sonoanatomical structures that it is very commonly understood today. He is very well published. I need not say he is extensively quoted in many publications. His work has led him to lecture at many, many conferences around the world. On a side note, he's also a big Rolling Stones fan, and many of the time he jams with the band and sings some beautiful Rolling Stones numbers. Hopefully someday when we are together, we would do that in our venue. The second speaker today is another good friend of mine, Kenneth Sheah. He comes all the way from Singapore. He's not an anesthesiologist. He is a radiologist par excellence. He's a great teacher. He's very well known in the field of radiology. He's published extensively and teaches in many radiological conferences. Today, he will share with us his experiences and his know-how of how to use ultrasound and the anatomy pertaining to the thoracic region, which is pertaining to epidurals and paravertebral injections, given that he has an extensive experience and knowledge in the field of pain medicine. Just a few housekeeping matters. Since this is a webinar, the attendees have limited privileges. So you will be able to interact with us via the chat functions. So if you have any questions that you would like to pose to the speakers relating to any of these talks today, then please express them in the Q&A and do mention your name and where you come from. And one of our moderators will pick these questions up, and then we will discuss this at the panel discussion and the Q&A at the end of the webinar. So since you are from different areas, do remember to mention your name and your location from where you are coming from. Just a few other notes is that these are some of the books that come out from this university, from this institution. So if any of you are interested in acquiring this blue book, then do get in touch with us and we will guide you as to how you can get this book for your practice. So once again, a warm welcome to you all. And without further ado, I would now like to welcome Bernhard, Professor Bernhard Moriggl, to share with us his knowledge and experience on the functional anatomy relevant for thoracic epidural and paravertebral injections. Welcome, Bernhard.
Hi, everybody. As Manoj already mentioned, I'm a big Rolling Stones fan. And I dedicate this lecture today to Mr. Charlie Watts, who died unfortunately in the age of 80 prior to the starting of Rolling Stones tour in the United States starting September 26. And for myself, it's a privilege to share that this is, believe it or not, my lecture 1000 I give to you, and I hope I can give you some new insights for thoracic and paravertebral anatomy. Remember, that's what I said when we talked about lumbar. Not all of your patients will have perfect spines. And especially if you have severe obesity, it's not that easy sometimes to get to your bony landmarks, but better than in the lumbar spine. In the thoracic spine, even with obesity, you can palpate spinal processes and orientate yourself. But keep in mind, and I will show that to you again, one spinal process is not always above the other, and this is important for orientation. One general consideration: if you see a thoracic spine from posterior, I indicate the lamina, and the width of lamina oversees, that's much more than the width of body. That means in the thoracic spine, contrary to the lumbar spine, you cannot access, ultrasonographically speaking, the neuroforamen or the body of a thoracic vertebra, except the lowermost, and you will see that. So very different. And if you see the right-hand side of my image, you see there's an additional window, if you so wish, because the laminae of the lumbar spine vertebrae is very narrow, and in thoracic, it's very wide. I will do the same as I did with lumbar. We talk about interspinous, intertransverse now, that's new, interarticular notch, as I call it, interlaminar space, and spinal canal boundaries. If we have a look at the whole thoracic spine, left-hand side part, upper and middle and lower and middle on the right-hand side, you see the interspinal spaces. And if you come, for example, between 1 and 2, you will see part of the vertebral canal shining through. The same is true if you go 11, 12, but in the mid-thoracic, if you strictly go forward, what you see from posterior is bone. That means you're not going to the vertebral canal unless you put your needle from lower to upper and or from lateral to medial. And this is the interspinal space, and you see how steep the spinous processes are directed posterior and downward. And the intertransverse space considerably changes from upper thoracic to lower thoracic. So the intertransverse space is completely different in the lowermost part, for example, between 11, 12, 12, 1, or also between T10 and 11. And this is important if you do a transverse images. They are completely different from middle and upper part of the thoracic spine. If you do a transverse section through the spinous process, as indicated here, you will always see the transverse process of the next lower vertebra, not the same. That is also important. Not so, for example, if you scan spinous process of T11, there's no transverse process on the side, so it's completely different anatomy. And in gray, you see the interlaminar space. That is completely different from 1st down to 12th. So this is important for orientation of your probe if you want to visualize parts of the vertebral canal. As I said, in the lumbar spine, the interarticular notch, what I call it, it's the classic example of a TH6 in the middle, but in the upper, it resembles cervical, and the lower, it resembles lumbar spine vertebrae. And this is important to know if you want to access or if you have no chance to access the vertebral canal. Keep in mind, even if you come from lateral posterior, you see the interlaminar space, but many patients will have ossification of the ligamentum flavum, and then it gets even more difficult or sometimes impossible. So you have to know your limits of ultrasound. And this is a pretty normal spine, and see what the spinous processes do. They are directed completely different from one to the other. And if you combine those, it gives a wavy line instead of a vertical line that you could follow. Keep that in mind if you do your ultrasound scans. And something very important is if you see transverse process of 10, there's a tremendous change to 11. 11 has almost a rudimentary transverse process and is far more medial. So if you scan downwards from 10, just longitudinal, you will hit the rib and not the transverse process. And for paravertebral, from osseous side, it's important to see that in the upper part, the ribs are strictly in front of a transverse process. And the more caudal you go, the more will the ribs show up higher to the transverse process shape. That means sometimes, as indicated here with my exclamation mark, you have almost zero chance to go strictly paravertebral. So we have to do an alternative. That means more lateral in the intercostal space. And again, this is a transition zone to the lumbar spine. Ossification of ligamentum flavum in the thoracic area is very common. Not so in the lumbar spine, fortunately. And something also important to mention, if you see TH12, it almost has a transverse process as in the lumbar. We call it in anatomy, we call it, to good reasons, coastal process, because it's a material coming from embryology. That means it's rib material. And if you scan TH10 and 11, pictures dramatically change from one vertebra to the other. This is 10. Everything is known, spinous process, transverse processes like wings to the lateral sides. But if you scan TH11, for example, transverse process is so short and there's almost no lamina visible. Keep that in mind if you do your scans. And now we have to differentiate almost all of the 12 vertebrae, but I will point out the most important. These are the classical thoracic vertebrae, 5, 6, and 7. And you see the shape of the vertebral canal and boundaries dramatically changes down to TH12. And I will magnify that in a minute. Before we do that, see the orientation of the transverse process of TH1. That's almost pointing strictly lateral. And in 12, it's pointing posterior. And if you think that, for example, TH7 has a short spinous process, that's the view from above. If you have the same view from lateral, you see it's the longest of all spinous processes, but strictly pointing downward. What do I mean with this exclamation mark? The superior vertebral incisure, the mid-thoracic spine, especially 5, 6, 7, and 8, there's almost no superior incisure, contrary to the deep and really extenuated inferior vertebral incisure. And this is a good example where you see how close TH12 is as far as osseous anatomy is concerned to L1. The only big difference is the long, as you call it, transverse, I call it coastal process, and that's just a rudimentary here. But the bodies, and especially the vertebral canal, is almost resembling one and the other. Ligamentous, we have more than in the lumbar spine, supraspinous, interspinous, and of course ligamentum flavum. Then I made a gap because there's also intertransverse for approach to the paravertebral, and the so-called superior coastal transverse ligament, which is the key for entering the paravertebral space, the true paravertebral space. As far as the supraspinous ligaments are concerned, let me point out, as I did in the lumbar, that's always attachment to muscles also from the erector spinae and the thoracolumbar fascia. The difference is the thoracolumbar fascia in the thoracic area is not as tight and not as collagenous as in the lumbar. And if you see the interspinous ligaments, it's not as strong as in the lumbar, but very similar to the lumbar. It reaches the ligamentum flavum. That means it closes the gap that is sometimes present. And a remembrance on what I said on the lumbar. Keep in mind that the ligamentum flavum comes from the upper rim of a lower lamina and goes to the inner side of the next higher lamina. And this is all true to the different shapes of the aforementioned incisure. That means this incisure between articular processes. And in the uppermost, it's like this with the ligamentum flavum, and in the lowermost, it's like the one right bottom. A beautiful image of a longitudinal section where you see the ligamentum flavum, and this is the lamina of TH12. This is L1. It goes to the inner side, and in the lowermost part of the thoracic spine, the interspinous ligament is as strong as are they in the lower parts of the spine. Again, as I said, in the lumbar, there are gaps that's considerably different in different individuals, but in the thoracic spine, you have considerable gaps between the two ligamentum flavum of each side, and sometimes they're really, really big, as seen here. This is something you should keep in mind. And now I give you a mid-thoracic cross-section according to path of needle. That means if you come in a steep angle from caudal to cranial, for example, look at the thickness of the ligamentum flavum. It's just because the way is longer and you go from inferior to superior. And here is a beautiful gap seen as well. There's also some ligament that's almost forgotten. That's the intertransverse ligament. It combines the outermost part of the transverse process between two vertebrae. And again, this intertransverse ligament is combined to muscles, origins of muscles. In this case, it's one of the levator costarum muscles. And if you see opening of the intercostal space, you see the internal intercostal membrane, and the key ligament for paravertebral approach is nothing else as the medial continuation of that membrane. Don't mix the one with the other. If you see the ligament, you're intertransverse. If you see the membrane, you're intercostal. And this is the upper rim of a rib. And you clearly see it comes from rib to transverse process. That's why its name is given, coastal transverse ligament, but superior coastal transverse ligament. For the sake of completeness, there's also a lateral coastal transverse ligament. That's not so important for entering the space paravertebral, but it's very important for pain medicine. You can easily access this ligament and the underlying articulation. If you do a longitudinal scan, consider the orientation of the supracoastal transverse ligament, because the posterior surface always looks also medially. That means if you do a scan, don't do it just sagittal. You have to point your transducer outwards to get a beautiful image like this. By the way, if you don't do that, otherwise you will not have a clear image of the pleura. And you can do it alternatively in transverse scans. The only drawback is that the visualization of the ligament itself is not as good as in a longitudinal, but that's the advantage. Visualization of the pleura will be better if you do a transverse scan, especially if you use curvilinear probes, for example. Now we go to epidural. You see, for example of TH1, you see the difference between posterior and anterior epidural space. Don't forget, you always have a ligament that guides you, and this is the ligamentum flavum, now always pointed out in light yellow. And there is also considerable veins, and some of those veins are really, really big here in the so-called intervertebral frame, and I prefer to call that space intervertebral canal, because it's not just an opening, it's a canal. If you go lower, example T3, 4, you see the difference in the epidural space. And as mentioned in the lumbar spine, the distribution of fat is so different. It's not uniformly distributed through the epidural space. And now look at the ligamentum flavum. It got thicker the more caudal you go. And something to mention is the venous plexus. This is a beautiful example. And let me point out that especially during pregnancy, this may be very prominent, and especially in the posterior part. Again, you see the ligamentum flavum, and may I remind you of the fact that the ligamentum flavum, contrary to what people think, goes widely lateral, and that thus is also one of the borders of the intervertebral foramen, or as I call it, intervertebral canal. It's not only in the epidural space. TH11, 12, completely different again. You see the ligamentum flavum, orientation is completely different to the upper part, but you beautifully see the posterior and the anterior epidural space. Compared to lumbar, that's what we have seen in the last session, webinar 1. You see, there's almost no anterior, but there's a little bit of posterior epidural space. And you see parts of the cauda equina. Again, the ligamentum flavum, reaching far laterally, right posterior to a dorsal root ganglion. I mentioned that in the last lecture. I do it again. The architecture of collagen fibers in the dura is more complicated than you possibly think. And even near the midline, it's not just longitudinal, it's also transverse, it's also oblique. That gives you a network of collagen fibers. And this was described as early as in 1921 by Titus von Lanz. Very good work. The dural saccine cuffs, you know, there are cuffs reaching sometimes far laterally. And what is the difference, between upper, middle, and lower? This is number 1. It's a little bit ascending. In the middle part, it's almost transverse. And in the lower, for example, this is level 9, they do what the lumbar is going to do. That means they are steeply directed downwards. And now we go intrathecal. We have seen that. And now it's in the thoracic spine. A prominent thing is the ligamentum denticulatum, the denticulate ligament reaching from the pia mater to the arachnoid and dura. And you see a lot of nerve fibers beginning of cauda equina. And keep in mind, you see that beautifully attached to the dura, and it gives you a saw-like appearance if you combine this together. And as I said, in the lumbar spine, every little root that makes out the dorsal and the ventral root and then the spinal nerve has its own vascularity. It's not only the longitudinal anastomosis. Every little root has its own blood supply. And this is part of the fact that intrathecally you always have not only the denticulate ligament, you always have transverse aspects, and as seen here, the posterior septum. That is continuously throughout the thoracic spine. And you see a more or less, but not complete separation between left and right intrathecal space. And this is another example where you see how different those septa are in the intrathecal space, and they're considerably prominent. By the way, in the epidural, again, you see parts of the venous stuff pointing also out through this so-called intervertebral foramen. And to end up, I do the same as I did in the lumbar spine. If you put all those together and come now from interiorly to exteriorly, you will see body of vertebra, you will see posterior longitudinal ligament, anterior epidural space, dura, intrathecal space, posterior epidural space, and ligamentum flavum again, but not throughout the whole thoracic spine. And I showed you just 2 more images in ultrasound to get that right. And why did I mark here T? That means thoracic. It's not always as good as lumbar, but in the uppermost and lowermost part of thoracic spine, it's very, very easy to see the whole stuff. Not always the posterior longitudinal ligament as seen in this image, but the anterior dura. You see the posterior dura, epidural space, and ligamentum flavum. What's the difference to lumbar? You see that the window between laminae TH4 and 3 in this example is very narrow, but narrow does not mean that you don't see anything. So it's worth a try to do that. And in the lower part of the thoracic spine, for example, TH10 to 11, that's a typical step you see. TH10 lamina reaches far more posterior than TH11 does. But again, a narrow window. And in this example, you can even see the posterior longitudinal ligament, the anterior dura, the intrathecal space, posterior dura, epidural, and ligamentum flavum. And now it gets stronger because it is almost near to the lumbar spine. What's the difference now to the lumbar spine? Clearly seen in the next image. The interlaminar window is much wider. You see beautiful stuff, as mentioned, all written in that labeling down here. And the true difference is you see the cauda equina. That means in the thoracic spine, you will have all black throughout. And in the lumbar spine, or the transition zone between thoracic 11, 12, and so forth downwards, you will see the cauda equina, especially if you have young individuals. But remember, not all the lamina are as beautiful as seen here. So you have to get familiar with changes of the vertebral column also. And this was it. Say goodbye to everybody until questions and answers. And I hope you have learned something again.
Thank you, Bernhard. That was a wonderful lecture. You surely got the ball rolling. And what can I say? Yes, it's a sad day yesterday or a couple of days ago when Charlie Watts passed away, but he brought us a lot of joy to many of the Rolling Stones fans. Now I'd like to welcome another blues fan here, Dr. Kenneth Sheah. Are you ready?
2 weeks ago, we presented a talk about anatomy for the lumbar spine, relevant for central neural axis blocks. And today we'll be talking about the thoracic spine. And as you have heard from Bernhard, it's an extremely different anatomy. We'll do the same approach as we did the last time. So we'll start along the osseous anatomy, and then we'll discuss the ligaments, some of the meninges, the dura, thecal sac, and then the spinal cord. Now, the osseous anatomy in the thoracic spine is different. Taking as your representative vertebra, a typical thoracic vertebra somewhere in the mid-thoracic spine, I'm using the T6 vertebra to start with. Now, note here, you have the tip of a spinous process, but that does not belong to T6. And this again reinforces the fact that in the thoracic spine, like the spines of Godzilla, these are very long spinous processes, and they tend to overlap one another to a very large degree, and more than you would see in the lumbar spine. And therefore, if you look higher up in T1 to T4, your interspinous space is larger. It then comes down to a very small aperture in the mid-thoracic spine from T5 to T8. And then it starts to fan out slightly again from T9 to T12, eventually forming the lumbar spine. Looking back here, the most important thing you must remember is that the transverse processes are angulated posteriorly towards you. In the cervical spine, they tend to be slightly flatter, the same for the lumbar spine. And in the cervical spine, maybe anteriorly as well. But in the thoracic spine, they are angulated posteriorly, which means as you place your probe against the skin, you will be able to see the tip of a spinous process and then two echogenic structures almost at the same level, which represent the tips of the transverse processes. And this is a very important landmark. Adjacent to the transverse process are the ribs. The ribs have two articulations. One, the head articulates with the vertebral body, the costovertebral joint. And as you travel laterally, it then articulates with the transverse process and is bound by the costotransverse ligament. So this is the costotransverse joint. Moving slightly more inferiorly now into the upper end plate of T6 vertebral body, the spinous process of T5, we've crossed that. We've now popped under the transverse process, and you can see bits of the lamina. And down here, space potentially filled with ligaments, with vessels, and also nerve roots, approximating the thoracic paravertebral space. So this is an important landmark just below and inferior to the transverse process. This here, of course, is the vertebral body and the thecal sac and the spinal canal. Now, as you come slightly more inferiorly, you're starting to see the spinous process reappear. And together with that, you know that you are now at the level of the facet joints. And together with the facet joints, you start to see the top of the T6 rib appearing right here. Now, this is a useful safety device as well, because then you know that between the transverse process and the next rib, you have the thoracic paravertebral space. And the rib, in some cases, helps as a bony landmark to prevent needle migration inferiorly when you're doing an injection, for example. The facet joints also are angulated anteriorly, and this makes it difficult to approach from an axial direction. When we radiologists try to do a CT guided injection, we tend to use an axial image, an axial approach, whereas with thoracic, with ultrasound, sometimes we use this plane, the sagittal plane, an inferior to caudal approach. And that may be favored in the thoracic spine. As you move slightly more inferiorly to the inferior end plate of T6, that facet joint is starting to disappear, and then the rib proper continues from here again. Okay. Then from there, we move on to our MRI anatomy. I just want to quickly remind everyone, those who were here last 2 weeks will remember this. How do you differentiate the different sequences on a thoracic spine MRI? The same for lumbar spine. Firstly, go for the fluid signal. So the CSF signal is going to be your guide. T2 weighted images have a hyper-intense signal for the CSF space. And this reduces to almost a hypo-intense signal on T1 weighted images. Now, if we want to highlight pathology, remove the fat signal. As you can see from the T2 scan, fat signal in the subcutaneous tissues is almost as bright as CSF space. So we apply an inversion pulse, removing the fat from the subcutaneous tissues. It also removes fat from the vertebral bodies. It suppresses the fat signal and only leaves us with fluid signal around the spinal cord, the CSF, around the spinal cord, within the intervertebral discs fluid. And also, if there is pathology, within the diseased vertebral bodies and the spinous process here. And this is an inversion recovery or a stir sequence. Now, in order to highlight pathology even better, we will administer contrast. It's a heavy metal-based contrast like gadolinium, which is then taken up by the highly vascularized pathological tissues and results in relative enhancement of the abnormal tissues compared with the rest of the vertebral segments. And this is really the only reason why we will want to give contrast in the thoracic spine, or if there is abscesses. So it's abscess and tumors mainly. So once again, T2 weighted, T1 weighted, inversion recovery, and the contrast enhanced scans. Now this is a MRI through the whole spine, and we can now do this quite easily with modern MRI machines. Wanted to show you again the differences in anatomy at the cervical spine, and then as we transition down into the thoracic spine, the mid-thoracic spine, you can see how the interspinous spaces quickly disappear and how much overlap there is between the spinous processes in the mid-thoracic spine. And then they slightly open up again as you approach inferiorly into the lumbar spine. The CSF space around the spinal cord, and as you move laterally outwards, you don't see as much of the epidural space as you do in the lumbar spine. That means there's not as much epidural fat. But if you do see a lot of epidural fat in the thoracic spine, you must immediately think about epidural lipomatosis. As you're moving slightly forward to the lateral side, so you can see that the laminae also overlap substantially in the mid-thoracic spine from T4 to T8. And this gives you a very small working aperture. And now we're starting to approach the facet joints themselves. And you can see the facet joints in the thoracic spine were angulated more anteriorly and therefore not so amenable to access via an axial percutaneous route. But here you see you can still see the facet joints and their classic cranial caudal angulation here. And if you were able to slip a needle through here, you'd land on the articular process and walk your needle into the facet joint. And this is a more favorable approach in the thoracic spine without a curved needle. Moving slightly outwards now, you're starting to see the transverse processes take shape. And then here the neural foramina and their corresponding neurovascular bundles coming out to follow the ribs, which are slightly more anteriorly. And once again, you can see a few dots here within the intercostal space representing the intercostal neurovascular bundle. But once again, as you prepare for your case by reviewing an MRI of the thoracic spine, remember the axial scans that we perform for you are parallel to the disc, and this may not always be favorable to your planning of your approach, and therefore you must form a mental model in your mind before you perform a block or injection in the thoracic spine. So now this is at T1. We're just going to do a quick scan all the way down on MRI. Now, here's the tip of the spinous process. At the top here, this is going to be just at C7. This is going to be T1 vertebral body. Watch this. As we go down, this is the T1 transverse process, still looking fairly similar to a cervical spine. You can see the T1 rib taking its shape here. And T1 does not have a very nice or well-defined costotransverse articulation. The transverse process here is fairly short at T1. And you have a nice big space here where the neural foramen is. CSF surrounding the thoracic spinal cord. Moving now downwards slightly. 3, 4, 5, 6, 7. I'm just counting aloud just to orientate myself. This is almost at the T1, T2 disc level. And you can start to see that the facet joint is now no longer friendly and angulated anteriorly already. This is at T2, upper T2 level. You can see the transverse process. So the transverse processes are hinged on the upper aspect of the vertebral body. Don't forget. This is a well-defined costotransverse joint. This is at T2 level, costovertebral joint. Transverse process, laminar, spinous process. And as you come down again, the laminar falls off, as we showed you previously, and you are looking now at the inferior-most tip of the transverse process, and look at this big space here. This is fat-containing tissue, okay? But beyond that, this is only a few millimeters deep, and beyond that is the black space of the lungs, and this is where we don't want to go beyond. So now here is the so-called the classic thoracic paravertebral space, where below the transverse process, you see the nerve roots and their accompanying neurovascular bundles. And you can see how rich the conglomeration of vessels are around the nerve roots in this area. So you really have to be very careful and gentle as you enter. And if you're performing a procedure to try and hydrodissect a little bit to push away these vessels. Now, one thing on the thoracic spine that you will notice are these black shaded areas on the back of the spinal cord. It's very typical. You will see them on almost every patient that you see. If it's a young patient, they can be even more obvious. These are due to artifacts due to spinal cord pulsation in the thoracic spine. Very pronounced, but as long as they look like these black areas, they should be okay. You go back to the sagittal scan and make sure you don't see any big leash of vessels, because if you see large vessels in that area, then you're looking at a dural or a AVM of the dural space. So you have to be very careful about that. If you just see these dark areas alone, you don't see them on the sagittal, it should be okay. Or otherwise, just call up your friendly radiologist. Now, be careful. Sometimes you get really big vessels accompanying the intercostal nerves, and you can identify one of them here as well. So this area is a bit dangerous because it's very tight. There's not much working space, and there are lots of big vessels in the region. Coming down, this is still upper thoracic spine. We're looking at T3 now, a similar anatomy as T2. Coming down to the facet joint level. The moment you see facet joints, you'll be at the top of the rib already. And once you're at the top of the rib, the other important landmark then, if you're angling along the disc, parallel to the disc, you're starting to get into the intervertebral disc space. So this, sometimes for radiologists, represents a little channel through which we can access the intervertebral disc. It's this space which is relatively devoid, because this is the upper part of the rib, relatively devoid of large vessels. But once you move slightly inferiorly again, you start to see another sliver of tissue coming in. This is already the costotransverse joint again. So very tight working space. This is T4. And coming down, being just inferior to the transverse process tip, again, the thoracic paravertebral space with all the vessels in that area. Just about 3 to 5 millimeters below, you're starting to see the top of the rib again. So your angulation needs to be fairly precise. The rib acts a bit as a protection for you if your needle is angulated a bit too inferiorly. So always pull back if you feel the rib. And now this is at T5 level. Now at T5 level, it starts to change just a little bit. Where you used to, let me just show you this at T5 level, the transverse processes are slightly flatter now than they were in the upper part of the thoracic spine. There you can see this is at T4. T5 is coming down a little bit more horizontal. and it's starting to spread out a little bit. But again, the anatomy, the principles are the same. Inferior to the transverse process, just here, you're starting to get into the thoracic paravertebral space again. And then one more slice below that is the upper part of the rib. And at that level, the facet joint again. Okay. And now this is going through T6. And you can see sometimes the image will skip because our text will scan parallel to the disc. So don't be thrown off, right? So you have to sort of maintain this mental model in your head. So at this level, similar anatomy again with the ribs, the thoracic paravertebral space, and now coming up to the level of the facet joints again. And once you're at this level, slightly inferior to that, you're at disc level and rib proper already. Scanning downwards again, this is T7, T8. These are this is the mid-thoracic spine level. So there is some space, but because of all the overlap, the amount of clearance that you have from the inferior to the transverse process to the next rib is much less. You can see that in the upper spine, when I was scrolling, we still had 1 or 2 slices from the inferior aspect of the transverse process to the rib. But watch this, in the mid-thoracic spine, once you go below the transverse process of the rib here, the next slice is already, of the vertebral body, the next slice immediately, about 3 millimeters, is the rib already. So that working space sort of cramps down a lot in the mid-thoracic spine. And then now as we slowly approach the inferior part of the thoracic spine, we're coming up to T9, T10 level. You can see liver up here. It starts to then resemble again the lumbar spine. So we're coming downwards now. You can see that once again, the transverse processes are now slightly flattened out and very short. Okay, so this is what Dr. Bernhard was talking about. At the lower part of the thoracic spine, this is the cauda equina nerve roots, the filum terminale. So probably this is around L1 level, T12, T11, T10. Now this is where the anatomy changes drastically. From T10, you don't have a nice transverse process like you used to in the upper or the mid-thoracic spine. Look at how short and beady these guys are. The costotransverse joint is almost non-existent at this level. And as you go downwards, that very, very short transverse process, they used to be somewhere more lateral, but now they're really medial. So be careful about scanning too lateral because you will then fall off your landmarks in the lower part of the thoracic spine. Down here, just inferior to the transverse process, the facet joint starts to take appearance already. And again, down here, coming down to T11, T12 level, just very, very short transverse processes. And with that, they start to resemble the lumbar spine. Now, once again, just correlating the MRI with the CT anatomy. This is obvious. This is the cervical spine up here. The thoracic spine I've enlarged for you with some labels. But the point again is that the interspinous spaces are larger at the top. They start to cramp down in the mid-thoracic spine together with the interlaminar space, as well as the thoracic paravertebral space itself. And then it starts to flare out a little bit in the lower part of the thoracic spine. Similar for the interlaminar space, you've got a bit more working space down here in the lower thoracic spine. Over here, very crowded. And then as you move upwards again, slightly more space to work with in the upper part. And you can see again, appreciate from this beautiful anatomy of the facet joints and how they are orientated in a craniocaudal direction. A more favorable approach for facet blocks if you're using ultrasound guided injection to go craniocaudal into the facet joints rather than transversely. And just coming out here, you're starting to see the transverse processes all projecting outwards. Here, more facet joints resembling the lumbar spine with very short transverse processes. Now, this is a useful slide to show the principles that we were talking about. This is your patient, the back facing you, spinous process tips visible here, and the ribs and all the paravertebral musculature and how they are orientated. Remember that in the lumbar spine, the nerve roots tend to emerge obliquely and inferiorly along this kind of direction, like a Christmas tree. But in the thoracic spine, they emerge laterally and horizontally. And we have to be very careful about that. Now we're coming down along the transverse, the spinous processes go slightly more anteriorly beyond that. The tips of the large transverse processes in the mid-thoracic spine. You can see them very nicely here. You don't see them here anymore, partly due to the curvature, but also because the transverse processes are smaller as you approach the inferior part of the thoracic spine. This then is the costotransverse joint over here. And you can see that immediately inferior to the transverse processes, your working space allowing you to access the fatty tissue within the thoracic paravertebral space itself. So identify the costotransverse joint if you can, and that's also another landmark to tell you the most lateral landmark of the TVPS. Scanning again downwards here. Now we are approaching the spinal canal itself. You can see the TVPS over here very clearly. And this is a T1 weighted image. And so you see fatty tissue surrounding the neurovascular structures. And now we are approaching the thoracic spine itself. And this will give you a small portal of access into the epidural space over here. And then down the spinal cord appearing. So this is a useful way to think about the levels that you are at when you're doing your scan. Just a little image, from one of my procedures in the T8, T9 level. I was asked to do a nucleoplasty at this level. The patient had a little bit of a bulge down here. This here is the spinal canal, right? So, and then the whole gray area here is the thoracic spinal cord. The facet joints, and remember when you're at the facet joints, you should be seeing the rib adjacent to it, and true enough, you do have here. Now, so here's the needle coming in. I placed it first in the TVPS, so I used ultrasound guidance to nip the needle just under the transverse process and hydrodissected a little bit to give me a bit of clearance, and then I inserted the nucleoplasty needle with a curved tip. And here, if you can see around it, this has been washed away, unfortunately. We did the thoracic epidural injection first with a bit of local anesthetic and contrast. So you see these white little patches, so tracking along the posterior aspect of the thecal sac as well. That's confirming that we are in the thoracic epidural space, and that's coming out into the foramen slightly inferiorly. This is an angulated needle, so makes it more steerable. So from here, I know not to go medial anymore. I have to change the direction of the needle a little bit. So from here, I had to change the needle to point it more anteriorly, which is what we did. And as we went anteriorly, at the level of the facets, the ribs, you start to get the thoracic intervertebral disc space. And that's how we entered into the intervertebral disc space in the midline. And that is the RF cannula extending with a clear margin of safety away from the thecal sac. And that's a little bit of our epidural injection that we use to push the spinal cord slightly away from the needle path. So really that's it. I will show you a real life, a real case in a minute. Just wanted to hang up this little tribute slide to Charlie Watts, who was also a blues drummer. And we hope to meet everyone in Hong Kong in the near future. But let me just quickly show you a real case and then we'll walk you through it so you have a better appreciation. Just give me a second here. This is the patient with a vertebral compression fracture. So I think it's a good case for us to showcase. Okay, I think you should be able to see these two. You should have a sagittal on one side and a axial scan on the other. And this patient has a mid-thoracic vertebral compression fracture, two-level fracture. And as you're scanning, you try to imagine that you're doing an ultrasound scan for this patient, because sometimes they get referred pain. So the TVPS blocks can be very good to anesthetize the intercostal tissues. So now we are at the mid-level of the fractured vertebra up here. Once again, the classic anatomy, the facet joints, you know to expect the ribs to be at the same level. And once you're up here, you're at the upper lip of the intervertebral space down here. So once you are at this level, then you have access to the intervertebral space should you wish to have that. The facet joints, the ribs. Now, then we are now at the level of the transverse process again of the next adjacent vertebral level, the well-defined costotransverse joint, the costovertebral joint. There's no way to access into this level here. The transverse process again, the rib, and the rib starts to disappear. And now you're on the inferior lip of the transverse process. You can start to see the TVPS appearing, but you can see what has happened because the thoracic vertebral fracture has pushed the margins of the bone, retropulsed the bone a little bit, and that has made a very narrow working portal even more narrow than before. And you can appreciate that this space here is really, really small on this side. And then once again, just one or two slices below that, you're starting to see the facet joints and the ribs again, and not much space to work with after that. So this really sort of shows you the challenges of doing paravertebral or neural axis blocks in the thoracic spine. Be very careful about how the anatomy changes from upper to lower with the narrowest working portal in the mid-thoracic spine. With that, I would like to stop my sharing. Manoj, back to you.
Thank you, Kenneth, for a wonderful presentation. And I hope, ladies and gentlemen that are logged in here today, you will appreciate that how little we pay attention to the anatomy of the thoracic region, despite the fact that we are the ones that often more frequently place needles, whether it be epidurals or paravertebrals. And I'm also shocked that some folks in the journal of most unpublished research are often exhibiting their skills in spinal anesthesia in the thoracic region. Now, spinal anesthesia in the thoracic region may have a role, but I think from a safety point of view, given the anatomical illustrations that these two speakers have illustrated, would you be willing to have a spinal anesthesia in the thoracic region? If I were you, I would say no. So why would you do a spinal anesthetic in the thoracic region when you may be able to do an epidural? Anyway, this is a discussion maybe for another day. But thank you, Bernhard. Thank you, Kenneth. You really set the ball rolling. And I can tell you, if I were an attendee today, I would say, oh, wow, what a festival it has been, because nowhere you would see discussions of anatomy in so much detail and in so much extensive, expressions, particularly when the two of you have so much knowledge and experience with what we do on a day-to-day basis with our patients. In this next section, I'm going to talk to you about ultrasound imaging of the thoracic spine and the paravertebral region. I think from a clinical point of view, there are a lot of applications for this, and we will highlight some of that. I have no conflict of interest whatsoever relating to this presentation. Now, as we all know that thoracic epidurals have a wide application. in conventional literature, it's mostly used for analgesia, if you may, but certain applications can also be used for surgical anesthesia. So it's mostly used for anesthesia and analgesia that pertain to thoracic surgery that affects the afferent nociception from the thoracoabdominal level. So you can see here we have thoracic surgery, upper abdominal, lower abdominal, and even some reports of it used for urogenital procedures. There are many outcome advantages, not only from an analgesia point of view, but also improved outcomes from a pulmonary outcomes in terms of reduced pulmonary outcomes, reduced the duration of ileus postoperatively, and individuals that have major surgery where mechanical ventilation is performed, and these patients require less periods of mechanical ventilation. And there is also evidence that the use of epidural analgesia in patients with multiple fractured ribs can even improve reduce their chances of mortality. So in general, we are using it mostly to produce segmental analgesia. So unlike, say, when you do a spinal, you get an extensive sensory motor blockade below a certain dermatomal level. But in the thoracic level, you can achieve segmental anesthesia or analgesia depending on where you place your catheter and the use of a judicious use of volume of local anesthetic. I like to put this slide up, a paper by Dr. Bachman and their colleagues in a daring discourse in regional anesthesia pain medicine recently. If you haven't read this, I would welcome you to go and read this, because I think it highlights that we are slowly moving away from using epidural analgesia, because in certain quarters, folks are describing that thoracic epidural analgesia is dangerous. It can cause complications. Yes, there are complications, but this has to be performed by trained individuals. And given that the amount of literature and outcome data that is available with thoracic epidurals in major surgery is extensive. So not doing an epidural analgesia technique in a patient that is deserving, you are doing a disservice. So before I go more into this, I think I would like you to step back and think when you ever consider an alternative technique, because epidural analgesia does provide extremely good pain relief and improves outcome. So when we look at thoracic epidural catheterization, so what are the technical considerations? First is, how do you identify the given intervertebral levels of where you perform the intervention or place the catheter? So how accurate are anatomical landmarks? Needless to say, various investigators have demonstrated that landmarks, whether you use the C7 spinous process or the T12 rib, you only correctly, or the inferior angle of the scapula, you only identify the given intervertebral space is only about 20 to 25% of the time. Incorrect identification is very high. More importantly, I think the level you identify is often higher than what you anticipate it is. And the higher up the spine you go, the more accurate you become, more inaccurate you become. So I think rather than specifying a specific given thoracic intervertebral level, I think a good practice would be, as these investigators said, is to say that whether your catheter is in the upper, mid, or lower thoracic region. Next is, when you look at surface anatomical landmarks, it again would demonstrate that the higher the BMI of the individual, the more likely you are to be inaccurate in your identification of the given intervertebral level. So when you look at the cervicothoracic intervertebral spaces identification, anatomical landmarks when you use the vertebral prominence and you count down, or you use the L5S1 gap. Now that's way away from the thoracic region, but the lumbosacral junction, as we discussed in our webinar 1, is easily identifiable with ultrasound. And as these investigators have demonstrated, that you can count up to a given thoracic intervertebral level. But I say in clinical practice, I usually get dizzy by the time I have counted about 4 or 5 spaces, and then I'm more or less at a loss. So whichever approach you use, I think there is still, even with ultrasound, there is a chance for error. So I think using the concept upper, mid, and lower is probably more appropriate in clinical practice. So therefore, anatomical landmarks also correspond poorly with when you use ultrasound guidance. So which technique is most frequently used in our clinical practice? When you look at the lumbar epidural, this large-scale survey showed that it was usually through the midline approach was more common. And as we learned in our anatomy in our first webinar, the midline approach would be desirable in most individuals. Of course, with age and in certain groups of patients, when there is ossification of the midline, as Bernhard illustrated to us, then you may have to do a paramedian. But in general, majority of the lumbar interventions of the neuraxis can be performed through the midline. However, and as illustrated very eloquently by the previous speakers, in the thoracic region, it's usually a paramedian access for obvious reasons, and that we have seen in the anatomical illustrations. Also, when you look at the thoracic region, it is common practice to perform them in awake patients. Now, there's a lot of debate whether you should do it in awake or asleep patients. I think it would be prudent if you don't have to put the patient to sleep. Maybe it is safer to do them in the awake patients. Thoracic epidural catheterization. So how accurate is the paramedian access? Now, there aren't any large data to say how accurate you are when you do a paramedian access, but there are instances when you can see that individuals have punctured the pleura or even produced pneumothorax, not only of the ipsilateral side, but also of the contralateral side. So this illustrates that the medial deviation of the needle that one takes, if you deviate the needle too far, then it can go through the interspinous space into the contralateral paravertebral or even the contralateral pleura, if you may. So, so the paramedian approach is not without its hazards, and complications still continue to occur. So a system that would allow you to be more accurate and more precise is desirable. So I think ultrasound may help you to achieve that accuracy or more precision by being able to guide your needle to a given anatomical landmark, say in this case, the lamina. And I will illustrate to you in a short while. Also, when you look at catheter placement with, say, anatomical landmark-based techniques, as this group with Dr. Candido and the group have shown, that actually your catheter placement is often when you determine, is very inaccurate. And even with fluoroscopic confirmation, you can illustrate that the catheters are often many dermatomes away from where you had envisioned it would be. So let's take a look at what happens when you place the catheter. Catheter dislodgement is another issue that often happens with the thoracic epidurals, and subcutaneous tunneling has been demonstrated to reduce the incidence of dislodgement or misplacement of these catheters. So subcutaneous tunneling is often used in our institution, and you will find that catheters not only move outward, but also they can move inward. And by tunneling the catheter using various different methods described, you can often avoid this migration of these catheters. So what about serious complications? Fortunately, many large-scale audits have shown that serious complications are very, very rare. Of course, these are performed by trained individuals with appropriate training, and serious complications, however, still continue to occur. And if you see paraplegia, and some of the reports are maybe sometimes selective in some respect because they're often described in awake patients. Like you can see here, paraplegia from spinal cord injury after thoracic catheterization under general anesthesia. So I think this again illustrates that maybe we should try and do them awake as far as possible. But then you may also question whether this is really a foolproof system. Of course not, it isn't a foolproof system. And there are also publications that have reported that even with the cord, the needle within the spinal cord, the patient may not report any paresthesia or pain. So, none of whichever approach you use is not foolproof. And I think being prudent is the more important aspect for this. So today, ultrasound can be used to perform spinal imaging of the thoracic spine. And as the previous speakers have alluded to, the anatomy of the upper, mid, and lower thoracic regions are very different. Although there are numerous differences in the osseous and ligamentous anatomy at this different level, the orientation, etc. But I think if you consider upper, mid, and lower for your sonoanatomy, it also works quite well for clinical practice. Also, these investigators have shown that it's not always a paramedian sagittal, but also a slightly oblique scan, because in the mid-thoracic region, which will be our template for this discussion, the interlaminar spaces are quite narrow, and with age-related changes, they can even be narrow. That creates a very narrow acoustic window for you to perform the intervention, the scan, and therefore the intervention. Let's take a now look at how we can perform an ultrasound guided or ultrasound assisted thoracic epidural access. Before that, I'd like to just put here a publication that Dr. Pak and Dr. Gulati, the latter, Dr. Gulati will be joining us later on in one of the webinars later on. They described real-time ultrasound-assisted thoracic epidural catheterization. As you can see in the illustration that the transducer is not truly sagittal, but they have a slight pivot of the upper end towards the midline. So it's a slightly oblique scan with the cranial end of the transducer slightly pivoted towards the midline. This is another publication by Dr. Lee and the group from Korea, who also demonstrated that the transition of anatomy from the rib to the lamina, and then how you perform the slight pivot in the transducer, and then you can identify the narrow interlaminar space and perform the epidural needle placement and catheter placement through that. So the needle is inserted in plane from a cordocranial direction, and then you either contact the lamina and then walk over, or if your imaging is very good, you can just place it directly on where the ligament and flavum is. And as you can see here, because the ultrasound imaging resolution is not yet as good to tell you that the needle has entered the epidural space, we still rely on using loss of resistance. So you guide the needle to the lamina or to your interlaminar space so that the needle is engaged in the ligament and flavum. Then you place your transducer down, and then you can use your traditional loss of resistance to identify the space. So as you will see that in the study by Dr. Kim and their group, the first pass success was as high as 75 to 80%. I would think that's an exceptionally high rate of first pass success for those of us who are familiar with placing thoracic epidural catheters using the paramedian approach. That is something that I would want to do, and I would want to teach people to do on a regular basis. So let's have a quick review of some of the anatomy that are relevant for our discussion. And needless to say that the anatomy is different, and even within the thoracic region, the osseous anatomy varies, and this has been discussed at length. And for this discussion, we will focus mostly in the mid-thoracic region because that's more challenging, and this is where majority of the surgical procedures that are very painful procedures like thoracic surgery, thoracoabdominal surgeries, as you go down towards the lower thoracic region, as you will, those with experience will know that epidural placements in the lower thoracics are significantly lower. These are some of the vertebral elements of the posterior part that we have been discussing at length. Often in anesthesiology, we don't talk about the articular processes, the superior and the inferior. The lamina continues, and anteriorly you have the pedicles, but laterally you have the transverse processes and the previous speakers have already discussed that the size of these transverse processes vary, and the lower you go, they become very short. So the T6 is often used as a typical vertebra in the thoracic region. And I'd like to point out a few salient features that differ from a typical lumbar vertebra. Say this is the lumbar region. And Bernhard already illustrated a lot of them in terms of the shape of the spinal canal, etc. But I would like you to focus mostly on the transverse process, because this is an important feature, sonographic feature, that you'll be able to see when you perform an ultrasound scan. Look at the vertebra, okay? And then when you look at the articulation of the lamina, and you can see the lamina, and then it becomes part of the inferior articular process. And then the superior articular process articulates with the inferior articular process anteriorly to form the facet joints. So if you're scanning from a lateral to medial, you see the rib, the costotransverse articulation, the transverse process, and if you go slightly caudate to that, you'll start to see the lamina and then part of the articular processes. Now, why is this important? Because when we do a transverse scan, this can become relevant when you're doing a transverse interspinal scan. Take, for instance, you are performing a midline scan of the thoracic region of a typical vertebra. Now, as I think Bernhard already alluded to, so that the spinous process that you see may not really belong to the same vertebra that's showing you of which you see the other osseous elements. As you can see in this articulation, you see the spinous process, lamina, the transverse process, which is directed posteriorly, and the rib with its articulation. And in traditional anatomy, I would like to point this out, that these are the costotransverse ligaments. Now, often when you look at CT images, and I like you to take this note, Kenneth, and maybe we will discuss this later, is that in a CT or an MRI, you often see this like a dark space, as though there is nothing in it. Could this be an artifact? But normally, you will have ligaments that articulate between the ribs and the transverse processes. So when you perform a scan, you are seeing the structures like so, but actually the spinous process, like you see here in this typical, the spinous process actually from the vertebra above. And so when you do a transverse scan, it's not really very good to look for the neuraxis, but it can be good if you're looking for the spinous processes and some of the paraspinal muscles like we are in this case. But you can see a typical appearance where the spinous process continues the lamina, the transverse processes are directed backwards. You can see the costotransverse articulation laterally, and then the rib, which articulates with the transverse process. The interspinous view can give you access to the neuraxis, but as is known, it's quite narrow in the mid-thoracic region. So acquiring a transverse interspinous view can be quite challenging. On top of that, there are age-related changes or pathological changes because of disease or something that the patient's arthritis or other conditions that the patient may be suffering can lead to poor visibility. Again, calcification of these ligaments or osteophytes can also result in poor visualization. So therefore, the midline or the transverse interspinous view is not commonly used to perform interventions. Although in clinical practice, we do sometimes place needles to the midline. Although I haven't done one for many, many years now, I often use the paramedian, and the paramedian approach usually gives you easier and quicker access to the neuraxis, the epidural space. Paramedian sagittal scan, as illustrated here, you do it at the level of the lamina, and this is what you would see. And because it's quite narrow, also it is important not only from a neuraxial intervention, but also from a paravertebral intervention to know what structure you are visualizing in the sagittal scan of the thoracic spine. So I think you could look at these as illustrations for you. So you could have one at the level of the rib, you could have one at the level of the costotransverse articulation or at the level of the transverse process. And then if you go medially, you'll see the lamina. But in between, you can also have visualization of the articular processes, because while there are gaps in between the lamina, however narrow they are, but usually because of the articulation of the articular processes in the facet joints, there are no gaps at this level. But I find it's often very difficult to visualize exactly where the articular processes are. Take, for instance, in this series of sonograms, so the first one is the lamina, and the last one, the sixth one on the bottom right, is the rib. As you can see here, as you go from the medial to lateral, you can see the sonographic appearance changes. At the level of the rib, you can see they are more rounded. The pleura is very clearly visualized, and you can see the intercostal muscles posteriorly. As you go medially, you will see the costotransverse articulation with the ribs articulating with the transverse process and the transverse process. But look at the pleura. Now, this is a truly sagittal scan. So when you see the pleura, the visualization of the pleura can be very challenging at the level of the transverse process, although you can see the ligament complex posterior to it. And you have an idea that this is indeed the paravertebral space. But the pleura is usually poorly visualized, as you can see here. And as you go more medially, you will see the lamina and the interlaminar spaces and the narrow acoustic window through which you can see the ligaments, the epidural space, and the anterior complex. Now, these osseous anatomy can be visualized not by a true sagittal scan. It's usually a paramedian. It is sagittal, but also oblique. So the oblique, the amount of angulation will depend on the visibility of the neuraxis. So there isn't a fixed number that you have to use. It is gently tilt the probe more medially till you can see the interlaminar space and the underlying neuraxial structure, particularly the anterior complex. The anterior complex, which is formed by the posterior surface of the vertebral body, the posterior longitudinal ligament, and the anterior dura, can be a very useful landmark, a sonographic landmark, if you may, because if you see a very wide anterior complex, it reflects a wide interlaminar space. If you see a very narrow anterior complex, that means the space is very narrow. If you don't see an anterior complex, and provided you have made a good effort to insonate the ultrasound beam, then maybe that space is ossified. So you would rather prefer to use a space that you can very clearly visualize the anterior complex. Now, you can use a linear transducer. You can also use a curved linear transducer because the thoracic lamina in most normal habitus individuals are not very deep. I think linear transducers of about 12 megahertz are usually quite satisfactory. This is just to show you that the lamina of the thoracic region varies from the lumbar region. So many of you who are here with us in the first webinar, you can see that the lumbar lamina resembles a horse head, but this does not look like a horse head. It's more flattened with a narrower interlaminar spaces. So when you perform a scan in the mid-thoracic region and you do a paramedian sagittal oblique scan, so this is what you would see. Now note we are using a curved linear transducer. This is a 5 to 2 megahertz transducer. You can see from posterior to anterior, you can see the erector spinae group of paraspinal muscles. You can see the lamina, which are very flattened structures. Then between the lamina, you can see the interlaminar acoustic window. From a posterior to anterior, you can see the ligamentum flavum, the posterior dura, and between the two is the hypoechoic epidural space, and then the anterior complex, which is the anatomy I described to you, and the intrathecal space. So in general, the spinal cord is located there, but it's usually anechoic to the ultrasound. This again illustrates to you in more detail the flattened appearance of the lamina on a CT, and then what you see in an ultrasound image with the acoustic window in the mid-thoracic. This is a relatively young individual where the spaces are quite wide, and you can see the epidural space posterior to the posterior dura. So that forms part of the posterior complex, if you may. This is a scan in the lower thoracic region. You can see it's a much wider interlaminar space. And in this case, you can see a central echo, which I believe is probably the central canal that you're seeing within the spinal cord. formed by some of the ependymal layers that gives you this echogenicity. This is not common. I see that very frequently in neonates and infants, so I can relate to that, because in that, the acoustic window is very large when we do these interventions in neonates or infants, and you are able to see almost the entire neuraxis in front of you like a mirror, and then the central canal is very clearly visualized in them, like you see here. So there's good correlation with the lamina that we see from a CT, anatomical sections, and from the phantom. And Bernhard has already alluded to the acoustic window in the lumbar region is much wider. In contrast, the acoustic window in the thoracic region is much narrower. So therefore, your intervention at the mid-thoracic region is challenging, needless to say, even in your anatomical landmarks, but even with ultrasound, it can be quite challenging. Just for completeness, I'd like to show you a few images of the upper thoracic and the lower thoracic. This is a part of the upper thoracic. You can see here, the spaces are much wider. In fact, T2, T3 is, I find, is probably one of the widest in the upper and mid thoracic interlamellar spaces. And when I perform upper thoracic epidurals, as I used to do many years ago, I don't do them very often now. I used to choose T3, T4, or T2, T3, and often you can see that there's wide space. So performing ultrasound guided in these upper levels can be quite simple. What about the lower thoracic? Again, as you can see here, but for the appearance of the lamina, it has a very wide interlamellar window. And so therefore you can very vividly see the posterior complex, the posterior dura, the epidural space, and the thecal sac, with the spinal cord and the anterior complex from a posterior to anterior direction. So whenever you have the option, choose to use a lower thoracic epidural if you may, and then you will have more success. It's technically more simpler, and you will have more first pass success in that. And needless to say, the anatomy is more conducive to performing epidurals in the lower thoracic region. So when you look at ultrasound, these are some of the applications. You can use it to identify the midline. You can identify given thoracic intervertebral level. So what do I use? I usually use the first rib in a sagittal view, and then I count from the first rib to maybe the fourth, fifth, or sixth rib, and then you relate it to the medial anatomy and then identify the interlamellar space as a pre-intervention when you do a pre-procedural scan. It is possible also in patients with scoliosis to identify underlying scoliosis. If you are doing a pre-procedural scan and you find that the anatomy doesn't look similar and there are asymmetry in the position of certain osseous elements, and we'll discuss more about this in our next webinar. And Kenneth again will join us for that with many of his CT and MRI work. And we will then discuss how you can identify that. But for today's discussion, let's take it from me. You can also identify individuals that may have had previous surgery or instrumentation, because metal appears very bright and you have an acoustic shadow with a lot of reverberation artifacts. And in those individuals that you can identify the neuraxis, you can measure or accurately predict the depth from the skin to the lamina, and therefore the epidural space. Also, I think in light with the data that Dr. Chen and the group from Toronto have published in relation to the lumbar region, that when your ultrasound visibility is good at a particular level, that also means that that intervertebral space is wider and the chances of your success will be higher. So when you're doing a thoracic scan, I think the same should apply in principle, because if you perform a scan and you find that the view through T5, T6 is better than T3, T4, then I would choose that space, and therefore you can then choose which intervertebral level to perform the intervention. And then you can place your catheter. Now, these are a few images to just show you how you can use it in your clinical practice. Firstly, ultrasound equipment. Today, there are a host of different equipment available for you. And as I say, I don't have any financial interest in any company. But when you're doing difficult intervention, you have to have a system that has some muscle behind it. What I mean to say is that one shoe will not fit everything. So the imaging, the resolutions and the powers that most systems have will dictate what you see. Of course, if, as Bernhard mentions very often, is that if your mind doesn't know, the eye does not see it. That's very true too. We use very high-end systems when we do these difficult interventions, but these are equipment that we acquired through research grants, and we've been very fortunate. Second is the use of ultrasound gel. While ultrasound gel is used to couple the transducer to the patient and to reduce air-related artifacts, but when we do intervention to the neuraxis, gel is a no-no. Any gel that may reach the neuraxis in these animal studies have shown can induce severe inflammatory response. So in short, it may induce chemical meningitis, arachnoiditis, etc. So the question is, you should not be using it. So what should you be using then? In our practice, we use normal saline as the coupling agent, as I will show you in a short while. So use saline as the coupling agent, and that allows you to couple the transducer and overcome some of the artifacts. There is some deterioration in the quality of the image, but you can overcome that by using the overall gain in most cases. As you can see here, you can perform it in the sitting position or in the lateral position. Of course, maintaining strict asepsis is very important. Ergonomics is important. As you can see here, I'm at the posterior aspect. We're doing it from the back. I use my left hand because I'm a right-handed individual. So I often place them in the left lateral position, and the equipment is right in front of me so that I can directly visualize what we are doing. So from a technique point of view, it is truly very simple, because once you can identify the lamina, and they are quite relatively superficial structures, then you can, under strict aseptic precaution, advance the needle to contact the lamina, or as I said, to even place the needle in the interlamellar space where the ligamentum flavum is. Thereafter, you can use your loss of resistance technique as you would normally do, and then place a catheter as we do in most cases. Here you can see a needle being inserted from a caudal direction, from a caudocranial direction in plane, till the needle actually contacts the lamina. I prefer to contact the lamina and just park my needle there while I attach the loss of resistance syringe with saline, and thereafter I just walk it. I believe that this may circumvent the accidental deep insertion or movement of the needle, but I think with practice, either practice is quite satisfactory. As you can see here, the needle is now parked at with ultrasound guidance, and we are using a spring-loaded syringe. This is an early image, but you don't have to use that in your clinical practice. Or I'm saying you don't need to go shopping for this special syringe, because eventually we have to use loss of resistance. And as you can see here, this video will loop around. So you can see here that from the point of the lamina till you get loss of resistance, actually it's only about less than a centimeter or less than half a centimeter you get loss of resistance. And within the first attempt, you can usually acquire it. So I prefer air in most cases, in all cases, but I think you can also use air, and why not? But the important thing is not to inject too much air, because this will deteriorate any further attempts at your ultrasound imaging, because air will create a lot of artifacts. Place the catheter. The catheter is tunneled subcutaneously using a simple system, using IV cannula, and that's how we catheterize it. So what is the role of pre-puncture ultrasound? So you can also do a pre-puncture ultrasound as a pre-procedural scan, as a pre-procedural scan. So you can see the pre-puncture ultrasound can consist, as researchers have demonstrated, it can consistently visualize the posterior ligament, and you can obviously measure your depth and distances, and there is good correlation between the ultrasound measured depth and the eventual depth you often get. But more recent randomized studies, in double-blind randomized studies, have shown that if you perform pre-procedural scan, it does not significantly reduce the time required to identify the thoracic epidural space, but it may, in fact, improve your chances of first pass success. Today, there are very few, or there are no randomized controlled trials looking at how thoracic epidural catheterization is affected by ultrasound guidance. So what is the role of ultrasound guidance? This is a study that Dr. Jatupon Pakpiron and our group performed. The Pakpiron group is from Songkhla in Thailand. And so in this prospective randomized superiority trial, patients were randomized to either an anatomical landmark grace technique and an ultrasound guided technique, where the first pass success rate was the primary outcome variable, and 96 patients were randomized to these two groups. And you can see here, this is the sequence of images that as a routine was done from a lateral to medial to identify the interlamellar spaces, where the asterisk represents the interlamellar space. And then the needle, patient in the lateral position, the needle is inserted, as I've illustrated before, to the interlamellar gap, and then use loss of resistance, or in the loss of resistance to saline in the ultrasound, or if you're doing a landmark-based technique, whichever was favorable for the operator. We found that the first pass success rate of thoracic epidural catheterization was significantly higher when you use ultrasound. And I need not say why. I think this would be understandable. And when you look at the overall success rate, there was no difference. Actually, there's no statistically significant difference in the overall success rate, but the first pass success was much. So obviously the number of attempts, number of skin puncture was also significantly lower. Now, if you look at any intervention, whether it's in the lumbar or in the thoracic region, if you can perform the intervention in the first attempt and you need less needle punctures, so also the potential for causing complications may be less. And there is some data today from meta-analytic data showing that at the lumbar region, when you perform ultrasound-guided interventions, when you have less number of needle attempts, maybe the chances of bleeding, chances of complications are much less. However, it's important to understand these procedures take longer, about 5 minutes longer, but that's clinically not relevant when most of the surgery takes many, many hours. So the overall success is similar, but the first pass success is much higher. So because this was a superiority trial where the delta was 10%, the delta is the predetermined difference between the two was 10%. You can see that the red represents the conventional group and the blue represents the ultrasound guided groups. And you look at the 95% confidence interval, the lower limit of the ultrasound guide does not overlap the landmark-based technique. So that indicates superiority of one technique, that is the superiority of thoracic epidural with ultrasound guidance over landmark. So this particular manuscript is currently under evaluation. So ladies and gentlemen, in conclusion, today it is possible to use ultrasound imaging to identify the anatomy of the thoracic spine. Usually the interlamellar acoustic window is used to guide your needle to the epidural space. When you perform these interventions through the thoracic interlamellar spaces, we use the paramedian approach, and you still have to use loss of resistance. And but at the same time, it can also be quite useful as a pre-procedural ultrasound scan. So you can perform it both as a pre-procedural interventional to identify the various outcomes that I mentioned, and also use it for assisting your epidurals by guiding the needle to its target level. Okay, so I think with these few words, I like to conclude here. I think with this session, we are going to have a short break, which will be for about 15 minutes. So 15 minutes from now, we will return back and I will present to you about paravertebrals, and then we have a live demonstration and followed by a wrap up and question and answers. I know some of the earlier speakers, Bernhard and Kenneth, will have to keep waiting, but I really appreciate your wait. Thank you for now. Okay, see you shortly. Bye for now. Hello, welcome back. I think in the interest of some of the speakers that have to leave, we have a slight change in the program. I think if any of you have any questions for Professor Moriggl, then this is the time to ask through the chat. So if you have any questions, please do present them. Yeah, and Rossini is our moderator. She's one of our consultants in our department. And Rossini, are there any questions that have been placed for any of the speakers so far?
Actually, there hasn't been any question directed to the presentation content so far at the moment, but just a general question from Dr. Dave Otieno, who's just wondering if they can review these lectures again because they have a difficulty following all the material within such a short time, and whether or not there will be certificate for their attendance after the webinars.
Yes, Dave, welcome. It's been a while since we met each other, but yes, definitely you will get a certificate at the end of the entire session. All the webinars are over. They will be posted to you via email. Next is all the content will be available for reviewing after the end of webinar number 10. We don't want to post it before the end of the entire ISSPS because then people would not want to join it live. So only registered participants will get the opportunity to review it. So, and these will be posted after December. So after early December, you will be able to review all of the content. Now, I have a question for both of you, actually. Now, Bernhard, when we talk about the costotransverse articulation, often we read and we often see in anatomical dissections that this space is actually occupied by ligaments, the costotransverse ligament. And there's a very firm fibrous ligament that attaches the neck of the rib to the transverse process. However, when you look at it in a CT or in an MRI, you see it's like a void space. And in a recent wonderful paper, actually, I'm going to refer to that in my presentation that will follow, is that they have described a costotransverse space, which doesn't make sense because although that paper has wonderful anatomical reconstructions of a high definition or high resolution micro CT of a block of paravertebral anatomy, they seem to say that the costotransverse, the space between the rib, neck, and the transverse process is a space with no ligaments. What are your thoughts on this?
Yeah, thank you for this question. May I answer first?
Yes, please.
The problem is, I read that paper and I agree with you, there's something wrong because something in that paper they just took wrong. Apart from the fact that sometimes they mix medial with lateral, that's not the problem. The problem is the level where the scan is done. That means the whole space between rib, neck, and transverse process, it's a high space, okay? And it very much depends on which level you cut that, if it's more or less connective tissue and fat, or if it's ligament. It's just a question of level. So there's definitely a ligament, but it depends on the level where you hit it exactly. And of course, as always in the thoracic spine, it's not the same from T1 down to T12.
So you are saying that at certain cross-sectional anatomical plane, the space is void.
Yeah, you definitely see fat and connective tissue, which gives you the MRI signal. And formerly in the 17th century, this was called the ligamentum collicostae. That means the ligament of the neck of the rib. So that's definitely there. But again, it depends on where you cut it. And it's not directly transversely orientated. That means it's a question of level and how you do your scan.
So that means the ribs are indeed attached to the transverse process at that level with the costotransverse ligaments, which are the fine ligaments. What are your thoughts on that, Ken? Because my first impression when I read the paper was that it's a wonderful description of a lot of anatomy, but as you see here, but is this an artifact that we are seeing and they are interpreting it as a space?
Look at my axial scan here. It's MRI scan through the mid-thoracic spine. So if you follow the rib here, this is the rib articulating with the vertebral body. And this is the costotransverse articulation. Now, there is no signal here. This is all dark. And this represents the thick ligament structures because thick ligament structures usually don't give very much MRI signal. But then if you look more medially, Manoj, that's the transverse process, the rib, and you see a bit of space filled with fat. And sometimes you can get a vessel in this area as well. So I think, I'm not sure, I haven't read that paper, but I'm not sure if they're referring to this particular space. Once you get through somehow the articulation itself, there is a bit of a space in between. There's quite a long channel. Let me just measure that for you. And that's about 1.5 centimeters in length.
But the problem is, may I add that this is one section of one level. That's exactly at the costotransverse articulation. If you go more caudally, that means at the more end. Now you see clearly. Can you go back that? Can you go one? Yes. And now in the medialmost part, you don't see only fat, you see ligaments. Okay.
Yes.
That is it. It depends on the level. It's only 1 or 2 millimeters that differs in between having fat or having a ligamentous.
That is a very
over here.
Yeah. And let me add, because I'm a little bit I'm in a hurry because I'm on vacation. I want to leave earlier, if you allow. You will read a complete revision, a letter to the editor about that paper, Manoj, you mentioned. It's an excellent paper, but they did a few substantial mistakes. So you have to read it very, very carefully.
No, I'm pleased to hear your thoughts, Bernhard. But I think just looking at the images and the arrows that Ken has just placed on the image, that there's their interpretation that there is a channel from the paravertebral space from one level to the other, or the contiguous spaces through this may hold good, because if you inject into one paravertebral space, then could local anesthetic seep in from this space from one level to another through this so-called costotransverse space?
It is possible.
Yeah, this is something we have never considered in the past, and I think this is an important finding in some respect, because it may contribute to the craniocaudal spread of the drug. Because now,
what are the typical volumes?
Yes, of course, it depends on the volume, etc. But now we are only looking at a extrapleural paravertebral spread, as opposed to a costotransverse space spread. You know, yes, the space is not a continuum from the spinal canal to the tip of the transverse process, if you may, but there are ligaments, and as you two have alluded, that in the medial and lateral aspects are the costotransverse ligament. But that means some of the illustrations in anatomical textbooks are probably too simplistic. They show the entire articulation between the rib and the transverse process to hold the costotransverse ligament.
That's what I said. It's a question of level, because that's approximately the dimension of a rib and the transverse process, what I indicate to you. And not the whole space will be filled with fat, of course. And embryologically speaking, you can understand, because this so-called space is nothing else than a continuation of the transverse foramen of a cervical vertebrae where the vertebral artery goes through. So that's embryological, it's understandable, but it's not just pure fat and connective tissue. That's not true. And what I wanted to point out again, the authors argue this could also be a path for an erector spiny plane block to go to the paravertebral space, and this is definitely wrong.
Yes, I agree. Ken, can you put up one of the sections slightly lower at the articular process level?
Okay, we're going downwards now.
Where the exit foramina is.
Okay, we're coming down. So now going caudal to the transverse process, still here. You can see some ligaments filling this space, but it's not totally fibrous. Not like a sacroiliac joint
fibrous.
That's
what I said. It's not totally fibrous, but on the left-hand side of the image, you clearly see a combination. You see this?
That's right.
There's a ligament
over here
between. That's the ligamentum, ligamentum costo.
Transversal.
Ligamentum collicosta. That's the ligament neck of the rib. It's not the superior costotransverse ligament. It's not the lateral costotransverse ligament.
I can tell you after today, I'm the only radiologist who knows the name of this ligament.
Can you go slightly caudate, please?
All right, we're going caudate now. This is coming up to the tip of the transverse process here. TVPS appearing, and a bit more here.
More.
Yeah. So in the MRI,
stop there.
There's
okay,
also
I have a question here. Now, Bernhard, when we talk about the superior costotransverse ligament or the superior costotransverse ligament intertransverse ligamentum complex, usually it is described from the rib, as you said, to the lower end of the transverse process above, and it ends at the medial aspect where the costotransverse foramina begins, or where the posterior spinal nerve root emerges. Now, this study seems to indicate, and with very convincing images, that the costotransverse ligament actually attaches to the vertebral body anterior to the vertebral canal, exit foramina.
No, again, that's a crucial misunderstanding. If you have a look at their drawings and illustrations, they indicate the superior costotransverse ligament to attach to the next higher rib. Really carefully, they're just wrong. It's just wrong.
No, I'm asking you about the medial extension. Now,
the medial extension is clear because there has to be an opening, because the dorsal ramus that goes posteriorly has to go through that. That's why.
what about the ventral ramus? The ventral ramus goes through the medial slit of the superior costotransverse ligament.
No. That's wrong. That's definitely wrong.
But that is in situ images with very high resolution CT, and this I can say can be reproduced using ultrasound. And you can see the costotransverse ligament and the retrocostotransverse space as they have described. But
yeah, but no nerve. You don't see any nerve there.
No, you can't see nerve for sure. But as you see, maybe the MRI can illustrate a bit more here. Can you pick up the costotransverse ligament, superior costotransverse ligament here, Ken?
If you see that ligament, it clearly divides anterior, that means ventral ramus, from the posterior, and the opening from the medial side of the superior costotransverse ligament to the vertebral column is just because the posterior ramus has to pass first, and of course vessels. We know that for centuries, so it's nothing new.
I'm not sure if this is what we're looking at. Yeah.
Yeah. And do you see that it attaches to the transverse process?
Mm-hmm.
Okay. And they say it attaches to the next higher rib. That's just wrong. So please read it carefully and wait until the letter is published. And I did a response in detail. There's a lot of errors. Sorry.
Yeah. So the ribs end here, Manoj. This is the bit of the ribs. And then I think Bernhard is correct, because now you're looking at transverse process coming in. And then potentially this ligament here is attaching to transverse process and across to the rib, to the vertebral body.
Yeah, to the vertebral body.
Definitely there's crucial and essential mistakes they do, despite the fabulous illustrations they have. But their interpretation is wrong.
Okay, Rossini, any further questions?
So we actually have some comments from the chat box from several attendees. Dr. Noel Apa and also Dr. Ali Salvas-Siddiquis. Pardon me if I cannot pronounce your name correctly. There had just been some discussion on the whether or not there are comments on local anesthetic spread regarding erector spinae plane block and thoracic paravertebral block after, with all the anatomy and radiological evidence that was presented by our two wonderful speakers today. So just see if you have any comments on this.
Dr. Siddiqui and my other colleague, I would urge you to just be a little more patient. I think we have an entire webinar number 8, that will discuss at length. We will have the group from Korea, folks from the United States, Dr. Barrington, and those people who have done the work, anatomical, radiological, and then the non-believers like us will also be present, and we will have a good discussion. So I would welcome you to that webinar for that discussion, if that's okay with you. Okay, so if there are no further questions, I'd like to take this opportunity on behalf of all the attendees and our organizers to thank Bernhard. You've been a great teacher. Your insights are exceptional, and keep safe, keep healthy, and I will see you soon, my friend. Take care. Bye-bye. Okay. Ladies and gentlemen, for the next presentation, I'm going to share with you our insights into paravertebral sonography and ultrasound guided paravertebral blocks. As we have already discussed, there is some new concepts, but I will try to stay away from it because we need to still validate some of this in clinical practice. But nevertheless, these are interesting times, and you will hear a lot more, so you should stay tuned. I will refer to this to this aspect in this presentation. Firstly, I have no conflict of interest. But whenever you see this red star, do pay attention because these are important take-home messages, and I hope you will find them useful. These are, again, the books that highlight many of these aspects of spine, paravertebral anatomy, and if you're interested, I would urge you to consider them. So now, first of all, let's take a look at the history. We often forget about history. Epidural anesthesia was first described in 1921 by Fiddle Pages. Now, actually, if you look at my last presentation, we said Corning actually performed the first epidural injection, although he claimed it was a spinal, because he did not document any efflux of fluid. So that controversy was eventually settled because August Beer reported very categorically that before he injected the drug, he could see fluid efflux. But then clinically, Fiddle Pages, he is from Spanish military surgeon, once again a surgeon, described epidural anesthesia. Now, when you look at paravertebral, this was described in 1905, almost 16 years before epidurals, by Hugo Selheim from Leipzig in former East Germany. Actually, it was very interesting because I was in Leipzig many years ago, and Bernhard was also in the same lecture, and I was talking about paravertebral block, and I put up a slide, this same slide, and I said, this gentleman, do you know who first discovered paravertebral block? None of them knew about it. And it was funny, a guy from China appearing in Leipzig, in the University of Leipzig, and telling them it was actually in these four walls that paravertebral injections were first described by this great man, Hugo Selheim. Okay, let's get on to business. When you look at anatomical considerations, the paravertebral space is a wedge-shaped space. It's bound anteriorly by the parietal pleura, posteriorly by the transverse process and the costotransverse ligament, medially by the vertebral body, the intervertebral foramina. The nerves emerge from the intervertebral foramina or the intervertebral canal and enter the paravertebral space into this wedge-shaped space. So when we perform an injection, we are performing an injection into this wedge-shaped space. This space actually is quite interesting, and as Ken has already alluded in his presentation, this space is actually very vascular. It's laden with fat. There are neurovascular structures. Even the dural sleeve actually comes out of this vertebral canal. And although this is a wedge-shaped space, the posterior intercostal nerves actually emerge from here. And then the sympathetic trunks are located more in relation to the anterior medial part of it with the rami communicants. So as a repository for local anesthetic injection, I think it is very important because it is a crossroad where not only somatic, but also sympathetic nerves are crisscrossing. So an injection into this space will not only produce somatic block, but also a sympathetic block, which is important for visceral analgesia. Next is in between the parietal pleura and the costotransverse ligament posteriorly, there is an endothoracic fascia. It is interposed between these two structures, as we demonstrated many years ago with this group from by Dr. Pintarik, that it is actually divides the paravertebral space into an anterior and a posterior part. So if you can see this purple incomplete dotted line, this is the paravertebral space. So you have an anterior and a posterior compartment. The somatic nerves are located in the posterior compartment, whereas the sympathetic ganglia are in the anterior compartment. These spaces communicate with one another. So the contiguous spaces communicate with the other space. In relation to the endothoracic fascia, which is this purple structure, you can see the neurovascular structures are lying posterior to it or deep to it, and the sympathetic fibers are located anterior to it. Now, in clinical terms, this is a fibroelastic structure, but we haven't really been able to demonstrate that it really produces any clinical relevance to our blocks. But I think it does play a part in some of the variability of the block that sometimes occurs with these paravertebral injections. And we have described this in the literature. Paravertebral ligaments, most of the time we talk about the superior costotransverse ligaments here. This is that structure attached between the neck of the rib and the inferior border of the transverse process above. And then you have the intertransverse ligament. So they, in fact, form the ligament complex, which forms the posterior wall of the of the paravertebral space. And then the nerve roots emerge from the intervertebral foramina. And so this wedge-shaped space, as you can see here, is anterior to the costotransverse ligament. And laterally, you have the internal intercostal membrane, which is the medial extension of the internal intercostal muscle. So depending on where you perform the intervention, the ligament you see or the membrane you see is different. So sonographically, it is important to understand this. Also, when you perform the scan, you can see here at the level of the rib, as Bernhard alluded to, you often see the internal intercostal membrane, sometimes even at the apex of the paravertebral space, like the tip of the transverse process, as Ken mentioned, you will see the costotransverse ligament will usually end somewhere over there, and the internal intercostal membrane starts. This is the paper, a wonderful paper by this group from Korea. Dr. Yang will be discussing many of these aspects in webinar 8. So hold on for those who want to learn more about this new development in micro CT anatomy. He has very kindly agreed to appear in our webinar number 8. But nevertheless, what is very fascinating is they performed a very high resolution micro CT of anatomical blocks of the paravertebral space, and then they rendered 3D images in various planes. Now, I may just, I don't want to take away everything from Dr. Huang because he is the person, but I like to just talk to you about, just mention to you that some of this new observation actually changes our concepts of paravertebral blocks. And some of the injections that are performed in relation to the behind the superior costotransverse ligament or in the ligament complex. And as I will allude to some of that in a moment. Now, if you imagine this is the sagittal cut from that micro CT, and this is a transverse rendition of the anatomy. Now, this is the transverse view at this level, okay, between the two transverse processes. Before I go there, this is what I was alluding to. As you can see here, this is the articulation between the rib and the transverse process. You can see there's a costotransverse space as they defined it, the CT space. Medially and laterally now I can see that there are some ligamentous, which is the costotransverse ligament. So they propose that this may be a conduit for the spread of local anesthetic from one space to another or into the contiguous spaces. Let's try and focus more on the anatomy related to the section B. So this is a transverse cut of the paravertebral space anatomy rendered in real time. This is undisturbed anatomy, ladies and gentlemen. So there's no dissection occur here. We have a block, and the CT was high resolution CT rendered. Now, what you see here is the vertebral body. I'm not sure I can show you the pointer, but I hope you can see the pointer, but never mind. You can see the vertebral body anterolateral medially, and then you have the intervertebral canal and the transverse process or the articular process posteriorly. This structure, I've just colored it so it just gives you a better perception of the contrast of the structures. So you can see the spinal nerve emerges from the intervertebral canal, the dorsal ganglia located here. The posterior dorsal rami is given off, and it divides into its rootlets and comes out to what would be the costotransverse foramina. This is your superior costotransverse ligament, and this is the intertransverse ligament. Let me go back if you can see that. Okay, so that's the ligament that we are talking about, the superior costotransverse ligament. And this is the intertransverse ligament that Dr. Sheah and their group demonstrated so eloquently. They also described the superior costotransverse ligament to have a medial and a lateral slit. The lateral slit was more close to where the internal intercostal muscle membrane commenced. And here in the medial aspect, close to the intervertebral foramina. So this is the medial extension of the superior costotransverse ligament into the vertebral body anterior to the spinal canal. The anterior rami actually emerges from this medial slit and enters the paravertebral space. So this is the true paravertebral space, and this is the retroparavertebral space or retro superior costotransverse space. They defined this as the retro superior costotransverse space, And this is the spinal canal or the intervertebral canal. So this is another space they document. And this is what would be the erector spinae plane. I don't want to go into this discussion because we are talking about paravertebral block, but as you can see here, this probably brings out new avenues of how local anesthetic can actually spread to produce analgesia without entering the paravertebral space. So you can see in a more wonderful demonstration here, this blue structure is the superior costotransverse ligament. It has a medial and a lateral slit. The spinal nerve emerges to give a dorsal ganglia, then enters the paravertebral space through this medial slit, and then the posterior ramus comes out into the superior costotransverse, retro-superior costotransverse space. And this is a view from the inside. You're looking at it from inside the chest. You see the spinal nerve, and this is the ventral rami. It comes out through this medial slit, lies on top of the superior costotransverse ligament, and progresses into the intercostal space lying on top of the internal intercostal membrane. There's this lateral slit between the internal intercostal membrane and the superior costotransverse ligament. So while these are interesting anatomical information, I'm sure it has a lot of considerations. And truly, Dr. Cho's demonstration illustrates that actually the paravertebral space anatomy has been redefined, if you may. So this is the retrocostotransverse space in green, and this is the intravertebral space, which is your spinal canal. And this orange to pink is your your erector spinae plane. This is the lateral and the medial slit, while the blue represents the traditional paravertebral space. So where you inject may truly influence how we achieve anesthesia or analgesia. I would leave it at that, and I think we can all ponder about it as to why these are not seen in CT or MRI, as can see in this image. It's actually one of Kenneth's image. You can see here that this is indeed the paravertebral space, but the resolution of MRI in this is not as high as the ones that the Korean group have used. So this may certainly be one of the reasons. But certainly, my take on it is that this may provide explanations for the mechanism behind some of the variations of thoracic paravertebral block injection techniques and injections that are performed into the costotransverse ligament complex or behind it, i.e. like erector spinae blocks. And these are some of the blocks that have been described without a well-established mechanism. And like the erector spinae plane, you have the mid-transverse process, midpoint of the transverse process to pleura block within the ligament complex, injection in the erector spinae again, or a costotransverse block, retrolaminar block, paravertebral and paravertebral laminar block described by a group in Germany. And more recently, the novel costotransverse foraminal block. So if you take the concept they've described, actually the costotransverse foraminal does not exist because of the space behind the superior costotransverse ligament complex. Okay, I'm going to leave it at that. Now, let's take a look at what is the mechanism of action with the traditional belief of anatomy. Okay, so when you perform an injection in the paravertebral space, it not only spreads to the paravertebral space, but also spreads to the intercostal, the epidural, and prevertebral root. It can also spread via the mediastinal connective tissue to the contralateral side, as we have demonstrated prevertebral spread. Now, epidural spread occurs in about 70% of individuals after a paravertebral injection into this paravertebral space. However, it is important to understand that the epidural spread is only a small fraction of the total injectate. It is usually ipsilateral, and it produces ipsilateral anesthesia, and segmental spread of anesthesia is usually greater when there is epidural spread as opposed to when there is no epidural spread. Now, the paravertebral spread spaces communicate with the contiguous spaces through the paravertebral space. So therefore, local anesthetic injected into one space may spread to the space above and below. Now, the role of the costotransverse space, we don't know, but as you can see here, if the costotransverse space were to be hollow and there is a communication, then local anesthetic can surely, as as hypothesized by the Korean group, can spread from one level to another. And without retropleural space spread, you can still have spread to the contiguous space through this. And these are some rendered CT images after injection. This was a patient who had paravertebral injection using loss of resistance to air for a paravertebral block, multi-level paravertebral block for radiofrequency ablation of a liver tumor. What I like to show you this is because look at how the air has, the injected, maybe a cc of air has done. You can see here, there's some retrolamellar space. There is epidural space, which is ipsilateral, the posterior part. There's intercostal spread. There is paravertebral spread and spread prevertebrally to the contralateral side. So you can get contralateral analgesia or effects of the somatic as well as the sympathetic nerves via this route without the epidural route. And generally you can see it's mostly ipsilateral multidermatomal contrast spread in this case. So it produces ipsilateral somatic and sympathetic nerve blockade. That's what we understand. Now, as ultrasonography and ultrasound guided techniques are getting more popular, I think we are beginning to understand that ultrasound guided techniques may produce a different pattern of spread than what a landmark-based technique used to. But I need to first highlight to you what are the data with landmark techniques. As Dr. Chima has demonstrated many years ago, and many of our work also shows that when you perform a single level injection, which say something like 20-25 cc's of local anesthetic like bupivacaine and ropivacaine 0.5%, you will get ipsilateral dermatomal spread of about 4 to 5 dermatomes. However, the range is more important. You'll see here that it ranges from 1 to 8. Sympathetic blockade was identified using thermographic images, and they are usually greater than the somatic block in the same individual. And this usually doesn't produce postural changes in BP or hypotension. Now, when you look at this, there are obvious limitations with a single injection technique. This is a single injection through a paravertebrally placed catheter in patients undergoing thoracic surgery. And you can see here that the distribution of the radio contrast is quite different. While the 1NB may represent the ideal spread, but you can see that it's a cloud-like, it is longitudinal, it is a mixture, some spread to the apex of the lung, and so on and so forth. So this produces some variability in the technique. So it's often very unpredictable what a single large injection can produce. And there is no correlation between the block, age, gender, weight, height, or the dose and volume of local anesthetic. So therefore, unlike epidural, if you increase the dose or the volume, your segmental spread of the block may not change. As shown in this, to your y-axis is the number of block segments, and to the x is the dose. As you increase the dose, you see there's very poor correlation. You can see that the correlation diagram, that there's no increase in actually the dermatomal spread with dose or even volume. This is showing you the effect of volume on the number of segments. Also, the onset of sensory motor blockade after a single injection is also very slow. You can see peak onsets take about 40 minutes. So what about multiple injections? So therefore, multiple injections produce more reliable radiological and clinical spread of sensory motor blockade. So therefore, when one wants a wide sensory motor blockade, it is common to use multi-level paravertebral injections. And therefore, when your objective is to produce surgical anesthesia, it is desirable to inject multiple injections. So today, ultrasound is common. In fact, the first report of using ultrasound for paravertebral blocks was not using it to guide needles. It was usually used by this group from Austria to measure the depth to the paravertebral space and then do the usual landmark technique in 2000. Actually, the first description in the of paravertebral using 2D ultrasound for real-time intervention was actually by this group from in the Japanese literature. This group, Dr. Hara and Dr. Shinichi Sakura from Shimane, described it using ultrasound to perform real-time intervention. I will come to that in what they did later. So when you look at sonoanatomy, understanding the osseous anatomy is vital. And as we have already discussed, the anatomy varies from one level to the other, upper, middle, and lower. Also, the morphology of the spinous processes and the lamina and the transverse process produces pattern that is very well recognized, as you will see in the image to your right, that the transverse process of the thoracic vertebra are directed backwards, where in the lumbar region, they are more or less horizontal, if you may. This is to accommodate the rib anteriorly. Now, this is important because when you perform a scan, you will see the posteriorly directed transverse processes. Also, I like to point out here that the relationship of the articular processes to the intervertebral foramina or the inferior vertebral notch. You will see here that it is through the intervertebral foramina that the ventral ramus of the spinal nerve emerges. And the inferior articular process is actually directly related to the intervertebral foramina. So what does it mean in terms of paravertebral blockade? So if you can identify the articular process, then the intervertebral foramina is just located anterior to it. So this is what I would like you to take. So then let's take a look at the transverse anatomy. When you perform a transverse anatomy, firstly, you have to identify the sagittal anatomy. The transition in anatomy is understanding the transition of anatomy is important. This is an eye-slice view of a 3D volume that we acquired of the paravertebral space. And we slice that volume into 1 millimeter slices from the rib to the transverse process or the costotransverse articulation. So at the bottom right, you can see the ribs. The pleura is very clearly visualized. As you go to the left and upwards, you will see the anatomy change. These are 1 millimeter slices. You will see at the level of the transverse processes, the costotransverse articulation, they become more bulkier. The pleura is less visualized, and the posterior ligamentous complex is now visualized in this intertransverse space. I showed you this image in my previous presentation. So again, as you move from the rib to the lamina, the anatomy changes. And this is something that you have to practice and learn to identify where you are performing the scan. So today you can perform a sagittal scan or a transverse scan. Today, many techniques have been described for paravertebral injections. And in fact, today there are no optimal techniques that so each one has his own individual preference. And I will try and describe some of this to you with the pros and cons. If you want to read an interesting and good article, is by Dr. Kenneth and their group, which published in Anesthesiology in 2015. This actually enumerates all the different ultrasound-guided techniques using the transverse or the sagittal scan and using different osseous landmarks with different approaches for needle insertion, etc. So what should you be using? We will try and address some of that in this discussion. So the sagittal scan, as I alluded to, you perform at the level of the transverse process. Usually high-frequency linear transducers are used. And when you perform a true sagittal scan, I like you to take a look at the relationship of the beam to the pleura. Now, this is obviously not anatomically exact, but we understand that there is an anteromedial reflection of the pleura towards the mediastinum. So, but however, as you scan in this area, it is also understood that you can see the costotransverse articulation with the transverse processes, the ligamentous complex with the erector spinae plane muscle group behind, and the pleura, which is usually very fuzzy. This is even with a very high-end ultrasound system. So therefore, this is one of the problems of performing a sagittal scan of the paravertebral space. That means visualizing the pleura is often a problem. And the deeper it gets with the bigger body habitus, it becomes more of a problem. So why is it? We really don't know the exact reason. But as I alluded to, I think if the beam is not at right angle to the pleura, then it might be an isotropy that is contributing. We have also found earlier on that if you tilt the beam slightly outward, which brings it probably more at right angles to the pleura, the visualization improves. So the pleura becomes much clearly visualized. You can still see the costotransverse articulation. But one of the pitfalls of this outward tilt is that you may actually be visualizing the rib. So too much outward tilt should be avoided, because then you won't be doing a paravertebral injection. You'll be doing a an intercostal injection. So the sagittal scan is the next option that we do, is the option that we have. And this is indeed the first approach that was described by Dr. Hara from Shimane. They used an outer plane technique. Just to illustrate to you, they inserted the needle outer plane, like so. They perform a sagittal scan. These are images from the paper. They were able to visualize the transverse processes, and they were able to visualize the pleura. But while they were able to delineate the transverse process, the ligament and the pleura, and they were able to measure the distance. They perform an outer plane injection. Turbulence to injectate was localized at the retropleurally, and anterior displacement of the parietal pleura was first described in this paper. However, it is important to note here that they were unable to delineate the pleura at the level 1, at the T1 level. We will come to that later on. Oops, sorry. So then you have a sagittal scan and in-plane needle insertion. Various investigators from Ireland, Dr. Orion and the group, actually perform a sagittal scan, and they place the needle in plane from a caudocranial direction, as it is very frequently performed by many operators today. But what they reported is very important, is that they had a difficulty in visualizing the needle as it was advanced. And this is a common problem with performing in-plane needle insertion with the sagittal approach, is that because the angle of insertion is quite steep, visualizing the needle can be quite challenging. So, and if you want to visualize the pleura, then you have a slight oblique twist to it, which again improves or increases the challenge for you. So nevertheless, it can still be used. And whenever I use it, which I rarely do, I often use the bony landmark as a backdrop, so that and then you slowly hydrodissect your way until you start to see pleural displacement anteriorly or expansion of the paravertebral space. And this is a technique that has been used, and you will see anterior displacement of the parietal pleura, indicating your needle has entered the space. So the limitation of this is poor visualization of the pleura and of the anatomy and the advancing needle. But again, having said that, if you are a proponent of this technique and you're familiar with it, then you have a very low incidence of pleural puncture and pneumothorax, as reported in this publication in regional anesthesia that reported more than 2,000 paravertebral blocks using this, where they use chest x-rays post-operatively to document any pneumothorax. They only had 2 in these 2,000 and 2,163 blocks. So it's quite a safe technique. You can also perform outer plane technique with a transverse approach. Now, the transverse approach is the next. Now, this is a approach actually that was first reported by Dr. Shibata and Nishikawa from Japan. And I'd like to present the outer plane approach first, then we go to their description. You can see this is a transverse scan at the level of the transverse process, and the needle is inserted outer plane. Like so, you perform a transverse scan, you acquire the image of the transverse process, and Dr. Daniel Marhofer and Peter Marhofer and the group performed this, and they identified the needle in outer plane, and once they contacted the transverse process, they directed the needle laterally towards the apex. So this was more a lateral paravertebral injections. As you can see, the white bars represent the sensory block, and the blue bars represent the MRI-related spread. You can see that there's a variable spread with the contrast. Even the sensory blockade is quite variable, quite consistent with the anatomical landmark data that I presented. So therefore, you can perform outer plane injections, but visualizing the needle is again very challenging. And this is indeed an intertransverse scan at the paravertebral intertransverse scan. You can see the pleura, the ligament complex posteriorly. And when you inject the local, you will see displacement and widening of the space. This is a technique, this is an alternative technique where, or better to say, this is probably a better technique where you perform a scan at the level of the transverse process. Now you can see the tip of the spinous process, the lamina, the transverse process, and the parietal pleura anteriorly. There are no acoustic shadow to obscure the pleura, and you can see the ligamentous and the complex and the internal intercostal membrane, and the needle is inserted from an outward to inward direction and is often described as the intercostal approach to the thoracic paravertebral space. As Dr. Shibata has illustrated in this diagram, the needle is introduced from a lateral to medial and placed at the apex of the paravertebral space, and you inject your local till you see turbulence, anterior displacement of the pleura, but actually the paravertebral space is in the dark side of the moon or in this acoustic shadow, if you may. We have been using a slightly side variant to this technique for over 10 to 15 years now. We perform many thousands of individual paravertebral injections, and I believe this is our go-to when we do perform these paravertebral injections using a transverse scan. It's an in-plane technique at the level of the articular processes. So instead of using a linear transducer, we use a curved linear transducer because it provides you a wide field of view. And contrary to what most believe, that low frequency transducers offer poor visibility, poor resolution, I think that is of the past with modern day ultrasound systems. So we have a routine that you must follow. You start the scan from the level of the rib. You go caudal till you only see the transverse process or the Dr. Shibata window here. And then you go slightly more caudate till the transverse process disappears. And now you see an osseous element, which is the articular process window. And as I mentioned to you, the intervertebral foramina is located anterior to it. So this is the sequence: rib, transverse process, articular process window. And remember, the nerve emerges and lies in front of the articular process. As you can see here, this is the articular process or the facet joint here. The nerve emerges. And so this triangular space is the paravertebral space at the intertransverse level. So this is very clear. It is at the intertransverse level, and it's at the level of the articular process. And when you see the ultrasound image, I will come more to that. You will see that this articular process, you can see this hyperechogenic structure, which is the articular process. And then you will see the pleura anteriorly and this ligament complex posteriorly, which continues as the internal intercostal membrane. So all the neural vascular structures that are in the paravertebral space are located in this wonderful space here. So this is the first window showing you the various anatomical structures I alluded to: the spinous process, the lamina, the costotransverse junction, the posterior directed transverse process, and the rib. You now go below the rib, you will see the transverse process and no shadow laterally, exposing the apex of the paravertebral space, which is the target for the injection that Dr. Shibata and Dr. Nishikawa described in this apical part. However, if you go slightly below the transverse process, you will see the medial part, which is the articular process. And then you see the entire ligament complex with the parietal pleura anteriorly. And this becomes the triangular true paravertebral space. And this is what we use for our paravertebral injection, injecting into this triangular wedge-shaped space. We do not inject close to the intervertebral foramina. But however, there is emerging evidence that injecting closer to the foramina is clinically beneficial, and I will come to that later. We usually inject somewhere between the apex and the foramen. So somewhere here is where we would guide our needle for the interest of safety. And so this is again to illustrate to you the three sonographic windows that you need to learn to acquire, and I will show you that in the demonstration. And then you can acquire the articular process window. And once you know the articular process, in your mind's eye, you would know where the paravertebral space is located. As you can see in this sequence of videos, this is the rib level, this is the transverse process level, and this is the articular process level where you can see this paravertebral space in this anatomical area here. So this is the triangular paravertebral space that is our target for injection at the articular process level. So demonstrated in the video at the mid-thoracic level, you can see the rib window. You can see the shadow of the spinous process, lamina, transverse process, and the rib. Yes, a bit of the pleura is visible occasionally with the tilt. Now we go below the rib, you can see the transverse process window. And this is often a case of slight tilt rather than a slide. So once you tilt it slightly further, now the transverse process shadow disappears, and now you can see the the paravertebral space in this acoustic window here. So insertion of the needle is also at the level of the articular process. This is our setup. It's usually an aseptic precaution in plane injection. And as you will see here, this is another good image of the paravertebral space at the articular process. So this is where the intervertebral foramina is located. The needle is inserted in plane, as you will see in the ultrasound window in the image there. It is advanced towards the apex and somewhere between the apex and the foramen. And then we inject some saline to hydrodistend the space and confirm that there is pleural displacement. This, to a certain extent, also excludes intravascular placement because, as Kenneth has alluded to before, this is a very vascular space. Injecting saline and pushing these veins away, and then incrementally injecting your local anesthetic, you will see the paravertebral space will distend up. There's increased echogenicity of the pleura. This is because of post-enhancement, widening of the space. And in some patients, you can even see the entire ligament complex becomes much clearly visualized. A pearl is that we tend to avoid going close to the foramen for obvious reason. Also remember the dorsal branch of this intercostal artery actually emerges quite close to this. And this can be in the line of fire if you're going very close to the periforaminal area. We've described multiple injections using this approach for surgical anesthesia during breast cancer surgery. Whether it works or not, this for a discussion on another webinar that we will be conducting later on in our series, and where we will teach you how to use paravertebral block for surgical anesthesia, and does multi-level paravertebral block provide surgical anesthesia on its own. So nevertheless, as you can see here, we put T1 to T6. We perform multi-level injection. Today, our practice is to inject T2, T4, and T6 level, 3 levels with ultrasound. Patients are sedated with dexmedetomidine after having received some midazolam during the block. We give them some ketamine also for the procedure during the block placement. They listen to music. They are awake, sedated, and this is the procedure being conducted. So stay tuned. This will be in webinar 9 on the 27th of November. This is a data not yet published, but we are in the process of preparing for publication. This is our experience over 6 years, where we did, in a single unit, we did 430 patients received multi-level or paravertebral injections of various types. Individually, about 1,400 injections were performed. There was a 0 incidence of pleural puncture or pneumothorax. Majority of the complications or side effects were related to the ketamine that we needed during the procedures. Of course, there were some incidences of vasovagal attacks, incidents of vascular puncture, and minor paraspinal hematoma. Otherwise, no major complication. Dr. Takeda from Japan, again, Japan seems to have a good history of paravertebral block. You can see from Shimane, it went down south to Dr. Shibata, and now to Dr. Takeda. I think he's from Sapporo. Anyway, it's an in-plane needle insertion with a medial injection technique using a low frequency. It's a small probe, and you can see here. This actually technique is not novel in some respect because it has been described by Louis in cadavers and also been described by Dr. Gautier using the lamina or the articular process and then direct the needle into the paravertebral space medially. So it is approach where you insert the needle very close to the midline, identify the lamina or the articular process, and guide the needle into the paravertebral space. Now, mind you, this is described as early as 1952. So when folks write that this is a novel technique, I think it just means that they haven't reviewed the literature well. As you can see, in 1952, Shaw described it in the Journal of Medicine that a medial paravertebral technique. Nevertheless, this novel paralaminar technique that Dr. Takeda has described using a microconvex array is interesting. While it is a general practice, I have always taught that we should not go close to the foramina, but Dr. Takeda has changed my practice. It is indeed maybe beneficial in some respect, and I will present some of his data. You can see this triangular wedge-shaped space. The needle is inserted from the medial aspect of the transducer, and because this is a a microconvex. It is not truly, it is and you can see the paravertebral outlines, and the needle is inserted using a guide from the medial aspect, and then you place it where the paravertebral space is and look for pleural displacement. This approach produced ipsilateral spread of the contrast in this cadaver study. The spread to the medial aspect of the paravertebral space and the sympathetic trunks was greater with the medial technique than with the intercostal approach. So therefore, medial spread may be more where the real crisscrossing of the nerves and the somatic fibers and sympathetic fibers are located. So what about the sensory efficacy, blockade and clinical efficacy with the ultrasound guided techniques? In this study by this group from Greece, they demonstrated, compared two intercostal approaches, transverse and a sagittal approach, and they found that the transverse technique, there was inferior in terms of the spread to the paravertebral space. There was a slight improved paravertebral spread with the sagittal approach than with the transverse approach. Clinically, this is again a cadaver study by Dr. Seidel and group using different ultrasound guided techniques, transverse, landmark guided, and using different volumes of injections. They found that the landmark technique produced unpredictable spread, as we already know. But the ultrasound guided technique, they used, which was a sagittal but a medial injection technique, higher volumes produced higher number of stained intercostal nerves. That means greater dermatomal spread, and epidural spread was also greater with the medial injection technique, like a paramedian sagittal oblique, compared to an intercostal approach. This is also shown in the lateral injection can produce variable spread and very variable spread of sensory blockade, as Dr. Marhofer and the group have shown. A single injection compared to a multiple injection was studied by Dr. Vishal Upal and the group from then London, Ontario, where they found that whether you perform a single or a multiple injection, which is 3 injections using a sagittal approach in plane technique, there are no differences in sensory blockade from the T1 to T10 dermatome. So the single injection produced comparable dermatomal spread as a multiple injection. So as you can see here, this looks a little different from the landmark-based technique. But however, these studies they use these blocks for analgesia, is to be seen if you can do a single injection paravertebral and perform surgical anesthesia. My feeling is that would not be possible on a consistent basis. Coming back for the last part is the paravertebral with the Takeda approach, which is the paralaminar approach. They compared intercostal with the paralaminar approach, where they looked at IV PCF fentanyl consumption as the primary outcome in patients who underwent post-thoracotomy analgesia. They performed the intercostal approach versus the paralaminar approach. They found that the paralaminar approach produces greater sensory blockade compared to the lateral approach, whether you test it with pinprick or cold test. The pain scores at rest and movement in the first 24 hours was significantly lower in the paralaminar group as compared to the intercostal group. Also, rescue fentanyl consumption was significantly lower in the paralaminar group. So this indicates that the paralaminar or medial injection techniques may be clinically advantageous. This is another study by a group from the All India Institute of Medical Sciences in New Delhi by Dr. Patnaik and their colleagues. They compared anatomical landmark-based multiple injection to an ultrasound-guided multi-level paravertebral block for surgical anesthesia for major breast cancer surgery. This is probably the first randomized study comparing landmark to ultrasound guidance for surgical efficacy. They found that the surgical success rate was greater with the ultrasound technique. More dermatomals were blocked with the ultrasound-guided patients. There was also less sparing of the T2 and T3 dermatomes in the patients that had received the ultrasound-guided block. So there are less sparing of the T2 and T3 dermatomes in the ultrasound-guided groups. Also, the pain scores post-operatively were significantly lower in the ultrasound-guided group. This may be accountable because the dermatomal spread was better. But however, I like you to focus on the number of patients that received rescue analgesia for various pain reported during various interventions like axillary dissection, pain during the supramammary area, during the povidone-iodine irrigation of the raw surface, you can see that 80% of the ultrasound-guided group still required rescue analgesia. So this will be discussed more in webinar 9, as I said, but as I said, alluded to the fact that the concept that multi-level paravertebral block can produce surgical anesthesia is wrong. It is not possible. You have to combine it with alternative techniques that take care of the afferent nociception that produce the pain when paravertebral blocks are effective. Also, Dr. Shibata and the group have shown that when you place a catheter with the transverse or the parasagittal approach in a randomized controlled trial, that there are no differences. Whether you perform a transverse or a sagittal scan, the catheters will be in the paravertebral space. So after this long presentation, I'm going to now conclude by saying that today there are different techniques for paravertebral injection. However, there are no optimal techniques described. Success seems to be superior with ultrasound guidance than with anatomical landmark techniques. So this is one reason why you should take up paravertebral blocks with ultrasound guidance, of course, after proper training in these procedures. Medial injection techniques produce greater epidural spread. There's wider segmental anesthesia. Also, clinical efficacy seems to be better than a lateral injection techniques. This is easy to understand based on the anatomy and the afferent nociceptive blockade that you can provide. Large volumes seem to be more advantageous than a smaller volume injection, but then it depends again whether you're performing a single level or a multi-level injection. The single level injections, although they produce comparable dermatomal anesthesia, which are statistically not different, but in the clinical validation needs to come when it comes to providing anesthesia for where multiple injections are required. I doubt that single injections will live up to surgical anesthesia as compared to, say, a 3-level injections, which produce very consistent multidermatomal anesthesia. There is a learning curve. Yes, it is technically more challenging than doing an ESP block, if you may, but it produces very high quality somatosensory block, the afferent nociceptive block that can actually abolish your somatosensory evoke potential. If you look up the data in the literature, there are no other blocks that have been documented that can abolish the afferent somatosensory evoke potential. Even spinals, even epidurals, when you perform somatosensory evoke potential from the, say, the sural nerve or the toe, and you measure them in the brain, you find that with spinals and epidurals, there is actually, patients do not complain of pain, but they are still afferent nociceptive signals that reach the brain. Paravertebral block, because of its high quality afferent somatic and sympathetic blockade, produces complete abolition of the somatosensory evoke potential. Yes, pleural puncture is a touted complication, I may say so. And sometimes it is used by scaremongers to scare you away from a paravertebral block. But the evidence in experienced hands is extremely rare, including ours. So I think just because it causes pleural puncture, it should not dissuade you from performing paravertebral blocks. If you perform it the correct way and with ultrasound guidance, I think the incidence is 0, as we have documented. The new anatomical data that has just been published is truly exciting. And I think this will change the way we think. I'm looking forward to hearing more discussion in this area. Dr. Huang will be with us in one of the webinars, so do stay tuned. And so stay tuned in this area. I think this is truly a very exciting area. So I thank you for your attention. I think for now, I think we have to go on to the live demonstration. So since I've shown you all this in extreme detail, I will just do a short live demonstration for you, and then we will call it a day. If you have some questions, you're most welcome to pose it in your Q&A. So just bear with me for a few moments. I'm going to go to our next studio, where I will then do the live demonstration for you. Okay, welcome back. We're going to do a short demonstration. Before I begin this demonstration, I'd like to thank VSonic for supporting this webinar and to bringing it to all of you across the world. How many do we have today, Brian? Okay, about 450 participants. That's quite good. I hope you enjoyed this session. I can bet on you that there are very few sessions you probably have attended that give you so much detail and anatomical facts and sonoanatomical tips and pearls like today. So as I said, all these presentations that we are doing will go up live on the web through our website after the conclusion of the 10th webinar, so which will be in December. So just stay tuned and be a little patient. Okay, so we have a volunteer here who's lying in the lateral position. You could have sat the patient up, but I think for comfort, this is usually what we would choose. This is the ultrasound system we are using. It is the Labat VSonic ultrasound system. And this is Daniel. He's going to be helping me. Hi, Daniel. Can we have the linear probe with the wider footprint, the 50 millimeter footprint, please? First, I'm going to use the linear transducer just to show you what it can do and what some of the limitations are. Although it's a higher frequency and you would anticipate higher resolution, yes, it is. But there are some limitations with it, and I will come to that. And as I showed you, that don't underestimate the power of low frequency transducers today. Okay, so we have a low frequency, this is a high frequency linear transducer. It's a broadband transducer which serves 15 to 4 megahertz. So we are going to start from the higher frequency range. And we have used a musculoskeletal preset. We have set the scanning depth to, so let me show you what we are doing. Can we go to number 3? So you can see we have set it to about 4 centimeters in 45 millimeters in depth. And this is a rectangular field of view that you can see here. So this is a fascinating ultrasound system because it has a lot of optimizability in quite much like some of the high-end systems that we use in our clinical practice. So having the ability to optimize the ultrasound system is the key to getting good images. So I think today ultrasound has become an integral part of our practice. So if you treat the ultrasound just like a point-and-shoot camera, then you'll be sorely very disappointed. I think being able to optimize the image is key to getting good ultrasound images. Because if you don't have good ultrasound images, then I think half the battle is lost in most of the cases. When I say optimizability, that means you should be able to choose the right frequency, choose the right depth, choose which most systems allow you. But most systems won't allow you to choose the right focus. They will not allow you to choose the right gray scale map that you may want. You may want to change the dynamic range. How does dynamic range affect the quality of the image? These are some features that I think is vital to understanding how to get a good image. Okay, that's a discussion for another day. So today, as you can see here, Ranjit, my fellow, has very kindly put some landmarks here. These are the oval structures are the spinous processes, and then you have the interspinous spaces in between. So we are going to focus our attention mostly in the mid-thoracic region. But let's come first to try and see if we can identify the ribs, okay, and how to identify a given vertebral level. Now, if you see here, okay, Daniel, can you increase the depth 1 notch for me? Keep going. Now see, we are increasing the depth to get to the ribs, okay? The upper ribs are usually deeper here. Now you see that the field of vision is becoming narrower and narrower. So one of the limitations of using a linear transducer when you're scanning at a depth is that your field of vision will become progressively narrower as you go up the spine, okay? Okay, so let me change to number 4. Okay. So now, if you see here, we have the first rib here, which is usually much smaller, and it's more cranial. Now, Daniel, can you please put it on the trapezoid, a wide scan, which is your field of view? Okay, we can make this the field of view slightly wider here. So let's do that. Okay, so now this is an extended field of view. Okay, so you can see it's slightly wider, but there are a lot of artifacts here. I can go back to the ordinary field of view. Right, so you can see that we can achieve a wider field of view, but you can see that's some artifact. So I need some more gel, please. Okay, so let's look at the first and the second rib. And then if I count distally, you'll see the third rib will appear, okay, the fourth and the fifth. Okay, so accordingly, you can count from, so this is a count down method. So you can count down from the first rib to more distally, okay? So as opposed to counting up, you can also count from the 12th rib and count your way upwards. This is more useful. I usually use that if I'm doing a lower thoracic. I count from the 12th rib and then count my way up. But I never count from L5S1 and go all the way up. As I said, it's really not very important to be very precise about T9 or T10. It's more important to say, is it upper, mid, or lower thoracic? So that's the first take-home message. Second is, I'm going to perform the scan somewhere in the mid-thoracic region, okay? And you can see here that the transitional anatomy I will show you as we come from a lateral to medial direction. You can see the ribs are more lateral. You can see here, we are scanning at a lateral, just below, somewhere near the scapula. You can see they are very rounded. You can see the pleura is very clear. It's very sharp. In fact, the intercostal muscles are very clearly defined. And as you go more medially, they become smaller because the transverse process will appear here. Now you can see it appears like a small cliff with a slight dip. The rib is anteriorly, and you can see the transverse process here. And this is probably where most people would do their erector spinae plane block. But now look at how the pleura is less sharp in this area. You can see at the intercostal space, the pleura is very sharp and clearly defined. But as you go medially, the pleura becomes less defined, right? So in order to, now this is the midline where I'm palpating my finger. This is the midline, and we are pretty much at the medial part of the paravertebral space. So in order to see the pleura clearly, as I alluded to before, slight tilting the probe outward. If you can see here, we are tilting the probe slightly outward, and you can see that the entire ligamentous complex becomes much clearer. While this improves your visibility of the pleura, but I think the challenge is the visualizing the needle can also become more challenging because you have a slight oblique tilt to the probe. So, so this is one of the things that we find may be a hindrance when you're doing a paravertebral injection using a sagittal approach. But I think proponents who use this can get very good at it. But this young man is relatively slim. You can see that the transverse process is only about 2 centimeters from the skin. So in individuals with slightly bigger body habitus, it may be quite challenging. And when the ribs become more anteriorly, as in some of the thoracic spaces, then this space can become very limited. In any case, it can be a useful site for performing paravertebral injections with low complications, despite the limitations that I alluded to. Okay, now once you've identified the space, let's take a look at the anatomy for epidural injections. Okay, we're going to, can I try your other transducer, the other linear transducer? So we're just going to change the transducer to maybe a slightly lower. We don't need such high frequency. That was 15. So this is also 15, but with a slightly smaller footprint, which makes the image also smaller. So we use the MSK preset. Yes, thank you. Right, you can see here, and now we need to increase the map or gain. What is the frequency here? Put it on general. Okay, general. And you can, no, the depth is okay. I think it's a very dark image, so I need to make it a little bit. You can go to the map. Don't increase the gain all the time. The map, grayscale map, yeah, a little bit more, brighter. No, go back. Yeah, okay. That's where you're seeing the rib. Okay. And then you can go to the transverse process. And as you can see, ladies and gentlemen, that even with good systems, sometimes visualizing the lamina can be quite a challenge using just the linear probe. So while the linear probe is quite useful in some individuals, it may not really fit the bill for every patient, as you can see here. So I'm going to switch over to my favorite, the curved linear probe, and I will show you the rest of the anatomy. So the take-home message is the linear probe, yes, it is a higher frequency, it's free, it should give you higher resolution, but sometimes the penetration and the image resolution that you get is quite limited. Now, the curved linear probe gives you extremely deep scanning, but you don't have to utilize the entire depth. We can actually reduce the depth. You can reduce the field of vision or the field of scan, so you can eliminate some of what you don't need. Okay, so, all right, so can you, right, the depth seems okay. Can you increase focus? We don't have here. So change the map a little bit. Okay, that's better. And then we can, what's the dynamic range you are using? I'll reduce it a little bit. Oh, okay, good. That's a little bit more contrast. Good. Okay, so now, first of all, I'm going to show you the same thing with identifying the ribs, okay? You can see here, it's very clearly visualized, okay? There's no doubt that's rib number 1, rib number 2, you go caudate, rib number 3, rib number 4, and rib number 5. So if you want to do it between rib 4 and 5, you can, at this level, you can identify it, put it in the center of the image, and then you can palpate the space that you feel in the midline corresponding to that level, okay? So you can place a mark here. This would, in majority of the time, this would be 4 and 5. So, but does it really matter 4 and 5 or 5 and 6? In my practice, it does not. So anyway, we have found that. Next is, I'm going to show you the paravertebral anatomy. So we are going to come from the ribs. They are more rounded. The pleura is very clearly visualized. And as we go medially, the rib becomes smaller. And then now you're seeing the costotransverse articulation. There we go. You can see there's a slight hint of a dip there. And then the pleura becomes less clearly visualized. And we are going further lateral till the transverse process is now seen. So at the true paravertebral space, you can, or at the very medial part of the paravertebral space, which is about 2-3 centimeters lateral to the midline, you can see the pleura is actually very poorly visualized. So often, I wonder if practitioners who perform these injections are actually performing intercostal blocks rather than paravertebral blocks. But definitely when you identify the anatomy, and you can see here that the transverse processes are quite distinctly sonographically appear different from the ribs. So therefore you can perform. Remember, visualizing the needle in the in-plane can also be quite challenging. So this is why I tend not to use this approach. Now I'm going to show you the first the paravertebral transverse anatomy, and then we will go to the epidural anatomy for thoracic epidurals. Okay, so we are going to do the scan at the mid-thoracic level. For your orientation, the orientation marker is to the top left, will represent lateral. So any transverse scan you see, that'll be lateral. And obviously anything closer to the probe is superficial. So I'm now going to place the probe transversely, and we'll offset it so that we are seeing mostly on the right side. As you can see here, Ranjit, can you focus down there? Yeah, very good. Now, the orientation marker is lateral here, okay? Now, in this case, you can see here, we are seeing the first window. Now, in this case, you can see the tip of the spinous process. Can you help me, Ranjit? You can leave the camera and just, can you put the pointer for me, please? Yeah, Ranjit, you just use this trackball. Yeah, you use the trackball. So that's the spinous process you can see there. Okay, the lamina you can see, which down here, yes. And the posterior directed transverse process. The transverse process directed posteriorly. And then you have the costotransverse articulation. You can see that some of the ultrasound is producing some reverberation artifacts in that area. And then laterally you have the rib. So this is the first window that we want to acquire. If I now slide the probe slightly caudad, you'll see the rib window will disappear. And now the transverse process window, or the Dr. Shibata window, is here now. You can see here the spinous process, and go inferiorly, the transverse process, and the lamina in the middle, okay? You can also see through the interlaminar space, we are seeing part of the spinal canal medially. So that is indeed the spinal canal, and you can see part of the anterior complex at that vertebral level, okay? Now, looking at the paravertebral anatomy, you can see the pleura is lateral, which is the hyperechogenic structure is sliding with the respiration. You can also see the thick ligament complex. Actually, here is the superior costotransverse ligament will become the internal intercostal membrane. And the apical part of the paravertebral space is actually just where the arrow is now. You can see there. So you can advance the needle from a lateral to medial direction like so. Insert the needle from here, and then it will emerge like so. And once you hydrodissect and you find your way into that apex, you can inject your local your saline first and followed by local anesthetic. Now, I would like now focus on the third window, okay? Now we come back again. This is the transverse process rib window. This is the transverse process window alone. And now we are going to just go below the transverse process. So now you see the acoustic shadow of the transverse process. Can we reduce the depth? It'll just improve the zoom of it a bit. Okay, that's good. So now you can see the articular process. This is actually that bright structure here. And then you can see the pleura laterally, and the anteromedial reflection of the pleura, you can see part of the reflection there. And then the ligament complex posteriorly, and which continues laterally as the internal intercostal membrane. So this thick ligament complex posteriorly is the superior costotransverse ligament, intertransverse ligament complex. So in this case, if you freeze the image and then use the measurement tool, yeah, and then just show how to do the measurement distance, just put distance, press distance. No, use tool, use distance. No, I want you to use the, yeah, and then show the needle. Oh, you do it, Ranjit. Put it near the orientation marker first. No, put it where the needle enters. More laterally near the orientation marker. Yes, more towards the skin. Yeah, so the needle would enter somewhere there, enter, and then move it towards move the trackball. Okay, we have some technical issues here. Move it to the edge of the film. Yeah. Okay, right. So now you can see this is where the path of the needle would take. You will see it now enter the apical part. We would inject some normal saline, see distension of the space, widening of the paravertebral space, and we would perform the paravertebral injection. So this is indeed your paravertebral injection at the articular process level. We find this quite objective, and indeed you can see the entire paravertebral space in front of you. You can also see increased echogenicity of the pleura after you inject and widening of the space. So these are all objective signs that you are indeed injecting into a tissue space. You are not injecting into a blood vessel, which can occur as it is quite vascular. Okay, now let's go back to, so this is about paravertebral scan. I just want to show you that the paravertebral anatomy in the lower part may appear slightly different. You will see here, the paravertebral space appears much wider. You can see here, this is the one of the lower spaces, okay? Probably T8, T9, or maybe lower. So this is your first window. If I go to the transverse process, you are now seeing the apical part of the paravertebral space. You can also see that the transverse processes are much shorter here. As Bernhard and Ken alluded to, the transverse process is much shorter. And then if I go just below the transverse process, you see the articular process, and you are able to see the large apical part of that space. So you can see here there's a large, often wider space. If I go to the next one below, you will see the space appears quite large. So I find paravertebral injections in the lower part much easier than when you perform it in the upper parts. But nevertheless, if you follow this, you can, your needle is actually tangential to the pleura, as Dr. Shibata discussed in his paper, that the needle direction is the same. But because we are tangential to the pleura, pleural puncture is rarely a problem because your needle is coming tangential to the pleura. It's not directly towards the pleura, but it's directed towards the foramen. So therefore, one must have good control of the tip of the needle, because if you do not, then you can inadvertently advance it too deep and it'll enter the intervertebral foramina. Okay, so this is about paravertebral windows and how you can perform paravertebral scanning. Now I'm going to show you how you can use this to perform epidural imaging, okay? So you can see here, now we are performing a scan, the same scan. You can see here, this is the level of the transverse process. You can see that the image is exquisite. It's very clear, it's very clean. The muscle in this young man is well developed. You can see the different layers of the paraspinal or the erector spinae muscle. As you go more medially, two things happen. The osseous structure become more bulkier and the pleura starts to become less visible. You can also see there are some artifacts starting to appear. And as you see, this is the paravertebral space. But in the sagittal view, it is quite limited. Now, once we have identified the transverse processes, one could see the articular process sometimes with the facets, but sometimes it's very difficult. So we are now going to do the paramedian sagittal oblique view, as I alluded to before. You can see the lamina are quite flatter than the lamina in the lumbar region, but you can see the acoustic window is quite narrow. But you can see the posterior complex with the ligamentum flavum, the posterior dura, and the epidural space, where the arrow is now. Go back to the epidural space. Just behind that, and the lamina are posterior. And the anteriorly, you can see the anterior complex, and the anechoic space is the intrathecal space, the spinal cord, and chorda equina, etc., which will be there in the lower level. So if I were to perform a scan in this individual, you can see this level is quite good. You can reduce the depth, please, if you improve the magnification. Yeah, no, not too much. That's good. So you can see here, in fact, now you can indeed see the epidural space very clearly. It's a very narrow space, but nevertheless, the epidural space can be visualized with a thick ligamentum flavum behind. Let's look at the space above. You can also see the posterior dura, the ligamentum flavum. So in this case, the aim is to guide the needle to the top of the lamina, if you may, or the interlaminar space, and then perform your loss of resistance technique. This will avoid you from directing the needle too medial, and therefore potential for contralateral paravertebral placement, or even contralateral pleural puncture. So these are some things that you can very easily avoid. And by advancing the needle in plane from here, you can easily guide the needle to the lamina or to the interlaminar space as you may, and then elicit loss of resistance. Often success on the first attempt is usually much better. So let's show you the upper spaces. The upper spaces can also be visualized, and you can see the upper spaces are sometimes quite wide. As I said, T3, T4 is sometimes much wider than most other spaces you can see here. Before I used to do paravertebral blocks, I did a lot of thoracic epidural at T3, T4 to perform breast surgery. So now you can see the entire upper thoracic window, if you may. So this may be the T3, T4 because it's quite wider in respect. Anyway, so let's take a look at the lower thoracic space. You can examine the lower thoracic spine here, and we go from a lateral to medial. You can see the ribs. We can actually go down and you can maybe find the 12th rib if you want. Yeah, go. So caudal is to your right. So you can see here, we are actually looking at the psoas and the kidney, and we are going upwards until you see the 12th rib. So you can see the 12th rib, and here we go, 12, 11, 10, and 9, okay? So let's go at 9 and 10. So if we look at the 9 and 10 level, you can see the, can reduce the depth a touch for me. Yeah, so you can see the interlamellar spaces. They are quite adequately visualized. The visualization of the interlamellar spaces are adequate. And you can guide your needle and use loss of resistance to identify the epidural space. I think you would agree that ultrasound imaging is not good enough today to tell me when the needle tip has reached the epidural space. Maybe in the future it will. But in the interest of safety, I think it is still prudent to perform the imaging and then use loss of resistance as you would normally do for a normal epidural to identify the epidural space. Okay, so I think we've had quite an extensive discussion. We've demonstrated to you. Let me go to F1. Okay. So I have demonstrated to you the sonoanatomy of the relevant for paravertebral blockade. I've also shown you how you can use ultrasound to identify the anatomy relevant for thoracic epidural, particularly the paramedian. I did not go into showing you the transverse scan because it's not really very useful when you're doing it for intervention. It's used for pre-procedural scan can be useful. So with these viewers, I think I'm going to end the live demonstration. Once again, thanks to VSonic for providing us this equipment for today. And thank you, Daniel, for helping us for the scan. And if there are any questions that the audience may have, I'm happy to answer them. And are there any questions, Rossini?
Hi, so we've got several questions from the Q&A box. So Dr. Ronil Nogi would like to ask your opinion on performing multi-level thoracic paravertebral block for breast surgery. So he'd want your opinion on doing multiple single levels from T2 to T4, T6, T2 to T6, every single level paravertebral block versus only doing T2, T4, and T6 paravertebral block instead. What would be your comment?
I think you should come, all of you should, if you're really interested in the topic, you should come for the webinar that has been specifically designed for this. I think it's webinar number 9, if I'm right. But anyway, to answer your question, with ultrasound guidance, we no longer do every individual injection. The evidences show that a single injection can produce quite extensive paravertebral spread. That may not necessarily be because of paravertebral spread. Some of it is contributed by the epidural spread. So if you inject a very large volume into a paravertebral space, it has to escape somewhere. And the epidural space provides a easy pathway for it to spread. So therefore, you can get extensive ipsilateral spread as Dr. Opal and the group from London, Ontario demonstrated. But to be able to use that consistently every day, Monday to Sunday, I think in my experience, I don't think it will be consistently possible. So we need to do multiple injections when you're doing surgical anesthesia. So what we also do, as you have asked, we perform injections of T2, T4, and T6. Now, you may say, what about T1? Actually, T1, the evidence would show that there is no contribution of T1 to the thorax. There's no dermatomal invasion of the thorax, anterior thorax, that comes from the T1. There's some contribution posteriorly, but the breast, one of the innervation of the breast comes from the intercostals, and they come from T2 to T6. So we do T2, T4, and T6, and we divide the total injected as 7 to 8 mils at each individual level. And that usually provides, extends this multidermatomal ipsilateral anesthesia that we use for paravertebral block, for breast surgery. But the question is, to you is, will this provide adequate anesthesia? The literature suggests that it does, but actually our clinical experience over more than a decade is that it does not. Initially, I used to think that maybe some of my paravertebral blocks are not working because we were doing it with Landmark. But more recently, we have been using ultrasound, using the articular process window, and we find that despite good pleural evidence of pleural displacement, other surrogate signs that tell you that your injection is in the correct location, still patients, 80% of patients report. And this is actually supported by the paper by Dr. Patnaik and the group from the All India Institute. They also reported 80% of patients will report pain when you do supramammary dissection, axillary dissection, maybe lower intercostal dissection, etc. So why this happens is easy to understand, because these are afferent nociceptive fibers that are not blocked by the paravertebral block. And how do you block this in order to provide surgical anesthesia? We have achieved that, and we will share that experience with you when you join us for that particular webinar. Thank you for your question.
Okay, thank you. So another question from an audience is, what type of needles are used for different types of paravertebral blocks?
That's a very good question. I think, as I alluded to, visualizing the needle with a transverse scan is quite challenging because the angle of insertion is quite steep. Although I don't use the technique anymore because I find the transverse view quite, because it gives a very good view of the entire paravertebral space, including the associated relationship, like the relationship of the pleura, the ligaments, where the articular process is. So you get a better three-dimensional conceptualization of the anatomy with the transverse view. Even with the transverse view, ordinary needles are sometimes quite difficult to visualize because now we are using low-frequency transducers. Often these transducers rely on compound imaging, and with compound imaging with multi-beam, where you are getting a summated information on your screen, it can be difficult to visualize the needle. So we use echogenic tip needles for these purposes, and we have found that echogenic needles are quite satisfactory. I know of many of my peers who use larger needles like 18-gauge Tuhi needles to perform paravertebrals, because bigger needles give you bigger visibility or better visibility. But I think bigger needles also cause more pain. So as a trade-off, I use 22 gauge. There are 22 gauge echogenic needles, and there are many that are available in the market today.
Okay, thank you. And then we've got some questions about the recommended dosage and volume and concentration of local anesthetic for a paravertebral block, and one specific question about any recommendation on the maximum dose of lidocaine before hypotension will occur when performing paravertebral block.
Firstly, I think if you use a paravertebral blocks, hypotension is very rare, even with extensive ipsilateral anesthesia. The ipsilateral sympathetic blockade very rarely produces hypotension. But having said that, This usually doesn't happen in awake patient because they are able to compensate for it. But sometimes when you use it in combination with general anesthesia, you will see that the blood pressure will tend to drop more than what you would normally see with a normal general anesthetic regime that you often give with induction and maintenance. But this is very easily treated with vasopressors, etc. Now, from a dose recommendation, if you're doing a single injection, we don't inject more than 20 to 25 mils total volume into a single level. That is based on our experience from landmark techniques. It is also based on our experience of pharmacokinetic studies that we have done. That these, if you say 25 mils, 125 milligrams of bupivacaine or ropivacaine, this produce a fairly low concentration that are below the threshold for toxicity. But having said that, often you may find the odd patient who will say, I feel a bit lightheaded, and the typical signs of prodrome of a toxicity, etc. But they will not develop toxicity. They may also sometimes develop some myotonic kind of activity, which is it is not conscious, it's subconscious, very transient. These are all indicative that the plasma levels are high. Now, in our pharmacokinetic studies, we have shown that the absorption from the paravertebral space is like giving intravenous drug. Now, this was all done by some kind of modeling related to IV pharmacokinetics of ropivacaine. We use paravertebral ropivacaine, but we found that the peak levels that developed were quite similar to what you would get if you gave them at the same rate the infusion intravenously. So remember that in absorption from the paravertebral space is very rapid and high levels can develop. So intercostal spaces may not always be the space that has the highest absorption rate. Paravertebral is also very vascular. The use of epinephrine or adrenaline in 1 in 200,000 reduces the absorption. So we, in my practice, in my unit, we often always add adrenaline to the injectate for two reasons. One is occasionally you may find that it may be your indicator of intravascular injection, but we rarely see it in our practice. But nevertheless, to reduce the absorption and reduce the potential for toxicity, adding epinephrine is advisable. So that would be my answer to your two questions. Any other?
So we've got one more. We've got a question from Dr. Pestari Sukmono to ask for your suggestion in the position of doing the scan. Lateral decubitus versus sitting upright position. And if lateral, then whether or not it's better to do it on the dependent side or the non-dependent side.
Good question, Sukmono. Yeah. As you can see, doing it in the lateral position is quite comfortable for the patient. Plus, so when you do multi-level injections, we often sedate our patients. So having a sedated patient in the sitting position is not desirable. So if you're using it for multi-level or even for single level, I find lateral position is my choice. But there are times when patients may be very large, very big, then putting them in the sitting position is what I would do. But generally, average Indonesian patient like yours or my patient in Hong Kong, we find them sitting, put them in the lateral position. But when you have them in the lateral position, it is important to have the ipsilateral arm away. So you pull it away as though it's hanging out from the other side of the bed. What this does, it makes this paravertebral area, which is medial to the scapula, much wider. So you get a good area of this. So this is why. And then if your patient is sedated with the neck slightly flexed like so, you can see I've just laid like that. And then we usually start some oxygen in a nasal cannula, 2 liters, and we sedate them with, we induce sedation with midazolam 1 or 2 milligrams, and we give them 10 to 20 milligrams of ketamine while we perform the three-level paravertebral injection. And with that, they usually don't recollect having had the injections. When you question them sometimes, or you quiz them in the recovery room in the PACU. So it's quite comfortable for most patients. And for performing the blocks, I think it would be advisable to do it on the non-dependent side, because on the dependent side, you will have a problem with visualizing where you're inserting the needle, as opposed to if you had it on the non-dependent side, then you are directly seeing the top end of the transducer, and it's much easier to place the needle at the center of the probe, where usually the plane of the imaging is located. So I usually do it lateral, but on the non-dependent side, because that's obviously, this is a unilateral block, so you should do your timeout properly, because you may sometimes place it in the wrong side. I admit I have done one paravertebral block many years ago on the wrong side, on the other side of the operation. So remember, these are unilateral blocks. So it is possible for you to, if you're not careful, to do it on the wrong side, which will be totally useless for a breast patient. So timeout is an integral part of our practice. And once we do the timeout, which is usually marked on the patient's back, we position them lateral, like in this lateral decubitus, with the arm extended out a little bit towards the other side, so that you are able to have that whole area exposed. So I hope that addresses your question, Mono.
Mm-hmm. Okay. So another question from Dr. Kenichi Matsuno. So they're wondering whether or not you have ever experienced seeing patients whom you couldn't find any interlaminar space with ultrasound for epidural anesthesia.
Hello, Kenichi. Nice to hear from you, and hope you will continue to join our webinars. Now, Dr. Matsuno asked this very interesting question, because yes, if I said I had never seen a patient where I couldn't identify an interlaminar space, I would be lying. Or maybe I wouldn't have done enough of this. It is not uncommon in the elderly, sometimes when you do thoracic epidurals, that it's very difficult to visualize the anterior complex. Now, I often treat the anterior complex as my friend, because if I can see the anterior complex, then I know there is a space. And you can imagine in the lumbar region, the anterior complex is quite wide. So the width of the anterior complex tells you how wide the interlaminar space is. And because the mid-thoracic region, the interlaminar spaces are quite narrow inherently, with age-related changes, with ossification, with pathology, etc., these spaces can become narrow. And also with age, there is loss of vertebral height, that is the loss of intervertebral distal width, etc. So the space, intervertebral space, inherently become narrow. So the interlaminar spaces are narrow. But for an experienced individual, if you can see a small interlaminar space and you know where the opening is, I think your experience, and I know you are experienced, your experience is all that you need to identify the epidural space, because you just want to find this, where is that possible opening, and then you can guide your needle through that. Now, there are times when you may not be able to do it. In that case, my advice to lesser experienced people is always look for the lower thoracic epidural if you want, because lower thoracic epidurals are much easier to perform. They are wider spaces, and you will, by and large, be able to place. But then you have to tailor your dose and volume requirements for the patient to achieve that segmental block. So yes, in some patients, you may not be able to see the interlaminar space.
Okay. We've just got some other questions about the surgery, like regional anesthesia for breast surgery again, which I think we can wait till webinar 8 to answer that.
Yes, and I think so. I think all breast related discussion we can have in that webinar, and we will do again a lot of demonstration or in videos, etc., specifically focused to providing anesthesia and analgesia for breast surgery. So stay tuned.
Okay.
Are we with it? Is that all, Roshini?
Yeah. I think
okay.
We've asked most of the questions.
Okay. As they say in YouTube, you don't have to ring the bell here, or you don't have to subscribe to this channel, but I like to welcome you to this webinar once again, when we come back again in a week's time, right? So we will be back in a week's time. So this will be rather than 2 weeks. I made a mistake, so never mind. We'll be back in a week's time. I like to see all of you back again for more excitement. Particularly, we are going to do difficult spine, scoliosis, etc., etc. So do join us again. I take this opportunity once again to thank Ranjit here, our people behind the scene, particularly Brian, Winnie, and Rossini over there, who has done a great job to collate all the questions. And I hope you had a great time. So with these few words, I like to say bye-bye for now. Stay healthy and stay wealthy. Take care. Bye-bye.
Thank you.
Thank you.